Good morning, everyone, and welcome to the International Medical Erasmus Conference. My name is Julia Ślążek, and I am a member of the Student Scientific Society of Child Neurology and the organizing committee of this conference. I am honored to be your host for today's event. We are thrilled to have you join us for a day full of insightful presentations and interactive quiz sessions. To kick off today's event, please welcome our esteemed speakers for the opening ceremony. Professor Tomasz Francuz, the Dean of the Faculty of Medical Sciences in Katowice at the Medical University of Silesia, and Professor Justyna Paprocka, the mentor to the Student Scientific Society of Child Neurology, the National Consultant in Child Neurology, and the Faculty Coordinator of the Erasmus program. Professor Francuz, you can share your screen and start your presentation.
Okay, thank you very much for this opportunity and a great invitation. On behalf of university authorities, faculty staff members, and myself, of course, I would like to thank to all our participants, guest speakers, thanks whom today's day will be a great opportunity to improve our medical knowledge, and I think that we'll spend it in a highly productive manner. Thanks to the organizers, I would like to tell you a couple of words about our university, which is one of the biggest medical universities in Poland, and especially about the Faculty of Medical Sciences in Katowice, because if you will use the mobility programs, like, for example, Erasmus+, it's a great chance that you will land here in Katowice at our faculty, and you will be more than welcome to see you here and to cooperate with you, because we are always open for any kind of cooperation and for our students from different countries. As a faculty, we are one of the biggest faculties in our university, actually the biggest faculty. We conduct for now 3 medical programs for Polish, European and international students. So as you can see, we have a program for everyone. So the program who in the best fit your best needs, no matter if you are European or you come from different countries. Especially, as you can see, we are focused on our European students as well as our American students, because we have a lot of affiliated hospitals, and it gives you the opportunity to make at least part of your clinical rotations in the United States. And that's why we are recognized by the United States government as the, let's say, local university. So when you graduate our university, you have exactly the same rights as you, after graduation of any American university. We have certificates of New York Department of Science, New York Department of Education, and California Department of Education. That's why we are widely recognized. As you can see, we are a really big faculty. We have 3,000 students. Among them, there is more than 700 international students. So we can say that we are creating a true multicultural environment, which is something we should really appreciate. This is one of the examples of many events we organize for our students. This is Multicultural Day. As you can see, truly we have students from almost all countries of the world, all continents, except maybe from Antarctica. We are still waiting for them. Okay, so our faculty is relatively big, as you can see. For such a huge number of students, we have to provide great opportunities for education. That's why we have 40 departments and about 40 different clinics, which covers all aspects of the medical professions, like, for example, by basic science, preclinical training, and the clinical training. And of course, we have a lot of different facilities, among which I think that the most important are 2, which are especially assigned to our faculty. One is the Center for Experimental Medicine and Animal Facility. So you have a great opportunities, chances to do any kind of experiments, medical experiments using the animals. And the Silesia LabMed, which is a special center for science and research. And especially if you are thinking about, for example, establishing a startup in biosciences, or maybe you're already owning a bio company and you want to conduct some kind of research or development, yeah, this is definitely a place for you. So this is how our university, our faculty looks like. Actually, now it's even more beautiful because not only we have a perfect weather, as you can see today, but because the university invests a lot to make this environment more user students friendly and more comfortable for all of us. So with a couple of pictures. And for those of you from our audience who maybe don't know the geography of Poland, I would like to say that we are in the perfect spot in Europe because our location is just in the center of Europe. So it means that we are nearby to any interesting points when you choose the Katowice as your destination point, not only for the study but for example for the Erasmus exchange program, definitely it's a place you can go, and we are, as you can see here. So because of this perfect spot, you have a great chances to face the rich culture of our Silesia region and Poland, but not only. If you are interested, you can visit some historical locations and very famous cities, like for example Kraków, which is very beautiful, and it's another location for another great medical university, Warsaw, which is the capital of Poland, Gdańsk, another beautiful spot on the map of Poland, and Wrocław. But if you want to face other cultures, other countries, because of the nearby location of our Katowice airport, which is a relatively big international airport, it's well communicated with a lot of cities in Katowice and not in Europe, but not only. So you have a chance to, for example, spend a weekend in beautiful spots like, for example, Prague, or maybe Vienna if you wish, or maybe Budapest or Berlin as well. So a lot of our students use these opportunities and spend highly productive their weekends, for example, in different spots in Europe because of the opportunity which gives us the location of the airport and, of course, the cheap flights which are offered by some airlines. But let's focus on our research opportunities and teaching opportunities and our university. As I told you, one of the biggest facility is the Silesia LabMed. It's especially dedicated for startups and different bio companies. However, if you want to conduct your research, you are welcome to do it there, no problem at all. And Education and Medical Simulation Center. It was established more than 10 years ago. At the moment it was established, it was one of the biggest and most modern simulation center in Europe, and still it's definitely one of the best one in Poland. And this year and next year it will undergo a huge transformation. So we think that it will be again definitely the best simulation center in the whole Europe. So you are welcome to practice your clinical skills, improve your clinical skills at this center, and I will give you, some hints how it looks like. Of course, we have different facilities which will provide you opportunities of training in highly controlled simulated environment, because we highly believe that it's very important for our medical students to give them safe opportunities to practice the medical skills. And later, of course, which is even more important, we provide nice opportunities to improve the clinical skills in our different clinical centers. There are 4 big clinical hospitals dedicated only to the students of our Faculty of Medical Sciences in Katowice, as you can see here. This is a huge medical centers. So they provide you very modern medicine. And in fact, a couple of heads of the departments are former, for example, the presidents of, let's say, European Heart Association, or, for example, Nephrology Association. So, yeah, we provide, not only the teaching, but the medical services on the highest possible level. And this is how it looks inside. So we have departments which covers, the full spectrum of medical knowledge, and we are really famous from, for example, cardiology and cardiosurgery. In fact, one of the first heart transplant almost 40 years ago was conducted in Zabrze. It's a nearby city to the Katowice, in the hospital which belongs now to the Medical University of Silesia. And of course, simulation center, which gives you the opportunity to simulate any possible condition. And this is how our campus, only dedicated to the basic sciences, looks like. I hope that in the near future, it will be looking even better. So this is some short information about hospitals. As I told you, when we have more than 3,000 students, it means that we need to provide a good opportunities for teaching for them, and that's why we utilize some hospitals, which are, as you can see, very, very big. It's one of a hospital near to our main campus, and another hospitals in the center of Katowice. As you can see, there looks pretty good and they are pretty modern and provide you a lot of teaching opportunities. So if you want to increase your skills in any part of medicines, for sure you will find, a nice place, a nice spot for you, which will fit your requirements. So this is another, it's the Children's Hospital, one of the biggest in this region, and one of the best hospitals in Poland, and in many fields, one of the best in the whole Europe, as you can see. Okay, so it will provide the teaching opportunities, especially if you are interested in our youngest patients and children. So I will skip this because I don't want to make this presentation too long, because obviously we can talk a lot about the opportunities provided by our university. However, you know that now we are living in the era of the very quickly evolving artificial intelligence. Of course, it's used already in medicine, but I think that we are one of the leaders in Poland in the field of using AI for the teaching of our students. And this is one of the examples. Unfortunately, please forgive me, it's in Poland. I didn't translate it. However, because of AI, it can be translated to any language, and it gives an opportunity to our students and postdocs, for example, to practice their clinical skills and assessment. Because of thanks to AI, it will give an opportunity to take the interview and make a full interaction with simulated patients. So you can basically, using this program, simulate any medical problems, any medical conditions. And of course, you have an opportunity to truly act as a doctor, and, for example, check your clinical skills and clinical reasoning. And of course, it will give you an opportunity to see something which is not commonly seen, for example, in the medical department. So, for example, some unique patients with a rare disease, and so on. And as you can see, you can really act as a doctor. So this is one of the opportunities we provide. Of course, we now are during the process of development of highly advanced virtual reality programs or augmented reality programs for our students. So it will provide another great opportunities to improve your learning skills and to learn in the very friendly environment. And later you will be able to transform this knowledge to your everyday patients. So, finishing my short presentations, I would like to say that we are warmly welcome everyone in our university. So if you will consider your mobility program, Erasmus Plus program, and you're looking for a nice opportunity, nice spot for spending another month or possibly years, we welcome you all. And definitely, if you choose our university, you wouldn't be disappointed. So again, I would like to thank for this opportunity to present you in a very short time, a little bit of our university, and I wish you, highly productive day, and thank you and welcome at our university.
Thank you, Professor Francuz. Now, Professor Paprocka for a few words, and then we will move on to the presentation.
Okay, thank you once again. Dear participants, dear students, due to time constrictions, I would like to also welcome you very warmly, and also thank the lecturers for their time, for their presence today. And I would like to wish you a very nice, successful, and wonderful conference. Thank you.
Thank you. So our first presentation of the day is by Dr. Jasper Boeddinghaus, an interventional cardiologist focusing on complex coronary interventions. He works at the Cardiovascular Research Institute Basel and the Center for Cardiovascular Science in Edinburgh, collaborating with top experts. Dr. Boeddinghaus will be discussing the use of high-sensitivity cardiac troponin in the diagnosis of acute myocardial infarction and the use of the European Society of Cardiology 0 to 1 hour algorithm. So, Dr. Boeddinghaus, you can share your screen using the green button on the bottom of the Zoom call.
Perfect. Thank you very much. Can you hear me clearly?
Yes, I can hear you clearly.
That's great. And can you see my shared presentation?
Yes, exactly.
Amazing. Perfect. So thank you very much for your kind invitation to this exciting meeting today. It's a really great pleasure for me to be here and to share some insights on the use of high-sensitivity cardiac troponin assays, and especially the ESC01 algorithm for the diagnosis of myocardial infarction. So these are my conflicts of interest. My research here in Switzerland is mainly funded by grants from the Swiss Heart Foundation and the Swiss National Science Foundation. So within the next about 20 minutes, I would like to share some insights on how we should use cardiac troponin in patients with a suspected acute myocardial infarction, and how we should use high-sensitivity cardiac troponin embedded in a rapid rule-in and rule-out algorithm. And the European guidelines, and I'm pretty sure you use this algorithm as well in Poland, for example, is the so-called ESC01 algorithm. So first of all, some background information about acute myocardial infarction. You all might know that it's a very common presentation, and it is an acute life-threatening condition. And 1 in 10 patients presenting to emergency departments worldwide do have symptoms suspected of an acute myocardial infarction. So we as physicians have to rapidly diagnose a myocardial infarction because time is muscle, and the longer we wait, the worse the outcomes of our patients. And we have effective treatments available, like early rhythm monitoring, the initiation of medication like dual antiplatelet therapy or high-dose statins. On the other hand, we also have to acknowledge that we should rapidly rule out an acute myocardial infarction. And this is actually the case in daily clinical practice in the majority of patients, because most patients presenting with chest pain to the emergency department do not have an acute myocardial infarction. So we're talking about more than 20 million patients presenting per year in Europe and the United States and Canada to an emergency department with acute chest pain. And only a minority, as highlighted before, will be finally diagnosed with an acute myocardial infarction. So it's our job to do an early triage and to get an early triage decision in this vulnerable patient population. And we have to rule out or rule in this condition, or we have to observe these patients in our hospital. So what do the guidelines recommend? There are actually 3 different diagnostic cornerstones. The first cornerstone is the clinical setting and the symptoms the patients present with. The second cornerstone is the 12-lead electrocardiogram that we should perform within 10 minutes after ED presentation. And then it's cardiac biomarkers that we should measure. And the guidelines are quite clear here. We should use a high-sensitivity cardiac troponin assay to measure cardiac troponin concentration at presentation and then at specific time points at 1 or 2 hours. And by doing this, we are able to triage our patients towards a rule-out, rule-in, or observe group. And the very important message here is that we should never interpret cardiac troponin concentrations in isolation, but always in conjunction with the clinical picture and the baseline ECG. We should not use cardiac troponin as a pregnancy test. It's not correct to say a cardiac troponin concentration is either negative or positive, because we know that the higher the cardiac troponin concentration, the higher the likelihood for myocardial infarction. And as we're using high sensitivity assays nowadays, we are also able to measure cardiac troponin in young, healthy individuals like us. So if we would measure cardiac troponin on you, in more than 50% of you, we would be able to measure a normal cardiac troponin concentration. So it's important to remember, the higher the cardiac troponin concentration, the higher the likelihood for myocardial infarction. The guidelines have changed over the last, let's say, 15 years. So in 2011, it was recommended that we measure cardiac troponin at presentation, so at 0 hours, and then again at 3 hours. And this became true with the introduction of high sensitivity assays. Before this, when we used contemporary cardiac troponin assays, we had to wait for 6 hours until we were able to measure the second cardiac troponin concentrations. With the 2015 guidelines, this was actually shifted from 3 hours to 1 hour, because the guidelines from then on recommended the ESC01 algorithm for use in clinical practice. The latest update in 2020 then also recommended as an alternative approach the so-called 02 hour algorithm, which means that we should measure cardiac troponin at baseline and 2 hours after presentation. So this is the concept of the EEC 1 hour algorithm, and it's actually quite simple. First of all, we have to make sure that patients do not have a large myocardial infarction, which is called an ST elevation myocardial infarction. If this is ruled out and patients have a suspected non-ST elevation myocardial infarction, then we should apply the EEC 1 hour algorithm. So we measure cardiac troponin at baseline, at presentation, and we can rule out an acute myocardial infarction in those patients with a very low baseline concentration if the chest pain onset was more than 3 hours ago. Alternatively, we can rule out an acute myocardial infarction if the first troponin concentration is low and if there is no significant 1 hour change. And most of these patients can then be discharged from the emergency department and can be treated as outpatients in our outpatient clinic. Of course, they should only be discharged if other life-threatening disorders are ruled out. On the other hand, we can rule in an acute myocardial infarction in patients with either a very high baseline concentration at presentation, or if they have a relevant 1 hour change in cardiac troponin concentrations between baseline and the 1 hour measurements. And most of these patients then need an invasive strategy, which means they have to be transferred to the catheter laboratory for invasive angiogram. And most of these patients are found to have a myocardial infarction. And then there's a third group of patients, and these are those patients who do not fulfill rule out or rule in criteria. And these patients should stay in the emergency department for a bit longer. We should resample and we should take another troponin concentrations at 3 hour. And they also need further cardiac investigations like a transthoracic echocardiogram or an exercise stress test. It's very important to highlight here that the cutoffs that we use for rule out of myocardial infarction and rule in, that they are assay specific. And you can see here in the upper right corner that there are plenty of different providers, different companies that developed high sensitivity assays in the last 15 years. So what we have done in our research group, we've actually derived and validated assay-specific cutoffs to make sure that the 1 hour algorithm works in this patient population. We have extensive data, prospective validation data, that shows that the 1 hour algorithm is very safe and effective. For the troponin T assay, for example, with specific cutoffs, we were able to show that almost 60% of patients can be ruled out by using the EEC 1 hour algorithm with a very, very high negative predictive value of almost 100%. And on the other hand, we can rule in about 20% of patients with a high positive predictive value. And this safe performance was actually validated in many, many different studies. And we've also shown that the 1 hour algorithm can be used in patients with impaired renal function and in the elderly, meaning in patients above 70 years. So the message is that the EEC 1 hour algorithm is safe and effective, including the use in the elderly and in patients with renal dysfunction. So this is one of the central table of the current guidelines. And again, I just want to highlight that we have two different algorithms available. It's the 1 hour algorithm and the 2 hour algorithm. And you see that for the different providers, like for Roche or for Abbott, we have different assay-specific cutoffs that we have to apply in clinical practice, depending on what kind of assay your institution and your emergency department uses in daily clinical routine. And we also have assay-specific cutoffs for the 2 hour algorithm. So it really depends what you use in clinical practice. It's important that you know your assay, that you know the characteristics, and then you can use these algorithms to rule out or rule in myocardial infarction. It's not only the European guidelines recommending these guidelines, but also the American chest pain guidelines that were published in 2021. And you can see here that they also recommend the use of cardiac troponin measured by a high sensitivity assay at presentation, and then serially thereafter at 1 or 2 hours. So the 1 hour and 2 hour algorithm. So it's really internationally recommended to use these algorithms in clinical practice. There is another field within high sensitivity assays, and this is point of care testing. And I just want to quickly highlight that this might be something that you as a younger generation will use in the future. And point of care testing means that we have small devices and not a central laboratory, and that these small devices are able to measure cardiac troponin and report back the results of cardiac troponin within 20 minutes, sometimes even faster. And this might be quite an attractive thing to use in clinical practice. And one area where we can potentially use point of care testing is the so-called preclinical use. So as we measure cardiac troponin on small transportable devices, in theory, we could use these in ambulances, and we potentially be able to measure cardiac troponin already before the patient actually arrives at the hospital. A second very interesting area is the use of point of care testing in rural areas. And there is data from New Zealand, for example, a very big country with a rather small population and not that many hospitals. And there is data that has shown that the use of point of care testing has actually significantly improved the management of patients with a suspected heart attack in Australian and New Zealand areas. We have also done some research on point of care testing. Published this a few years ago in the Journal of the American College of Cardiology. And what we've done is we've investigated how a new point of care assay, here depicted in light blue, performs in comparison to the best validated and most widely established laboratory-based assays, the Roche assay and the Abbott assay. And you can see in all patients that the diagnostic accuracy for the detection of myocardial infarction and the discrimination of patients, if they have an MI or not, was very, very good, with an area under the curve of 0.95. So the area under the curve compared to 0.94 for those measured with the Roche assay and 0.92 for the Abbott assay. And similar findings emerged in the subgroup of patients that presented early after the onset of chest pain to the emergency department within 3 hours. So very promising data showing us that point of care testing might be the future. These are the central illustration of this manuscript. We've investigated 1,200 patients. We measured high sensitivity cardiac troponin I with a point of care assay, both at presentation and at 1 hour. And we derived and validated an ESC 1 hour algorithm where we were able to rule out 55% of patients. So more than half of patients were directly ruled out with a very high NPV and sensitivity of 100%, which means that none of these patients that have been ruled out had a missed myocardial infarction. On the other hand, about 20% were ruled in with a high positive predictive value, and only 1 in 4 patients had to stay in this observed zone and then needed a second cardiac troponin measurement. Another very attractive approach is the use of only one single cardiac troponin concentration. So if a patient comes to the emergency department and the baseline concentration of troponin is less than 3 nanograms per liter, then 45% of patients were ruled out, again, without missing any patients with a heart attack. So this is great because we are able to immediately rule out a heart attack, and it's a very, very safe approach. And this avoids overcrowding in the emergency department. And this is like an international problem that too many patients are coming to the emergency department. And I mean, it also reduces the anxiety of patients waiting for their results. I mean, they're unsure what's going on, and they don't have to wait longer than half an hour until they've got the first result of troponin. On the other hand, the higher cutoff of more than 60 showed that more than 10% of patients were directly ruled in, again with a high positive predictive value. It's very important to mention those patients ruled out by these algorithms that none of these patients died within 30s, and that only 1.6% of patients died at 2 years of follow-up. So it's very safe to rule out myocardial infarction in these patients. So I would like to sum up. I've shown you the concept of the ESC 1 hour algorithm. I've highlighted that we have to use assay-specific concentrations. I've shown you that it's a very safe approach with a high sensitivity and negative predictive value for rule out of myocardial infarction. And that's an approach with a very high accuracy for rule-in, with high specificity and positive predictive value. I've shared some information on new developments like point-of-care assays, and I would like to stress that we now need evidence of large prospective randomized controlled trials, because so far most of the trials we have is our prospective cohort studies. But I believe that it's important to test whether the 1-hour algorithm is very safe and effective in a randomized controlled trial. So what we have done is we've initiated the so-called PRECISE-MI study in 2019. PRECISE stands for the prospective evaluation of the safety and efficacy of the ECG 1-hour algorithm's performance. And the aim is to directly compare the safety and efficacy of the 1-hour algorithm with the more conservative 3-hour algorithm, which is still recommended by the guidelines. So it is a prospective stepwise cluster randomized controlled trial where we randomize centers and groups of centers and not individual patients. And the in- and exclusion criteria are quite simple. We enroll all patients with suspected myocardial infarction at centers that would like to switch from the 3-hour algorithm to the 1-hour algorithm. And we only exclude patients with terminal kidney failure, those with cardiac arrest or cardiogenic shock. And what we then do is we look at safety, and safety is defined as all-cause mortality or myocardial infarction within 30 days, and efficacy, because we want to show that the 1-hour algorithm reduces the time of patients in the ED by at least 1 hour. We have to enroll more than 52,000 patients, and to date, we were able to enroll actually more than 60,000 patients at 19 centers in 10 different countries. And it's a non-inferiority design, and we are quite confident to present the first data in 2026 at one of the large cardiology congresses. And I'm very much looking forward to see the data, because this will for the first time really show us how safe and effective the 1-hour algorithm really is in daily clinical practice. I would like to thank you for your attention. I wish you all a great day. I hope this was interesting, and please feel free to reach out to me in case of any questions. Thank you very much.
Thank you, Dr. Boeddinghaus, for this insightful presentation. The depth of your expertise was very highly valuable for all of the attendees, and I'm sure the watchers of our conference afterwards will also appreciate this. Thank you a lot for agreeing to share your time and your knowledge about this. Thank you.
Pleasure. Thank you.
And next, we have a representative of IFMSA-Poland, the National Exchange Officer for Incomings, Julia Adamiak, with a presentation titled, If Not Europe, Go Global, IFMSA-Poland Exchanges. You can share your screen using the green button on the bottom of the Zoom chat.
Okay, just a second. Is the presentation visible?
Yes, everything is visible.
Okay, thank you so much. So good morning. My name is Julia Adamiak, and I am the National Exchange Officer for incoming students of IFMSA Poland. And today I'm gonna come with a little bit different presentation. And the title of the presentation is If Not Europe, Go Global, IFMSA Poland Exchanges. However, before I start, I would first of all like to congratulate you, congratulate the whole organizing committee for organizing this conference and for giving us the opportunity and the space to talk about all of the interesting topics that we have on the agenda today. Second of all, I would love to thank you for inviting IFMSA Poland to the International Medical Erasmus Conference. I believe that this is an amazing opportunity, not only for us to present what we do and what we love and what we have in common with Erasmus, but also an amazing chance for us to get a little bit out of our little bubble and to get a little bit more informed about what Erasmus also has to offer. Okay. So before I get to the exchanges, I would like to introduce you to what IFMSA is and to the structure of it. The International Federation of Medical Students Association, IFMSA, was founded in 1951. It is one of the largest and the oldest students-run organizations. It represents, connects, and engages every day with an inspiring and engaging network of 1.3 million medical students from 139 national member organizations in 130 countries around the globe. IFMSA is divided into 5 regions, that being Africa, the Americas, Asia Pacific, Eastern Mediterranean, and Europe. And these regions were created almost over 10 years ago in order to make it a little bit more easier for our members to tackle similar issues on the regional level. IFMSA works on the local and national levels, mainly via its 6 standing committees, and each of the 6 standing committees is focusing on major health topics and medical student-related interests. These standing committees are the Standing Committee on Public Health, Human Rights and Peace, Sexual and Reproductive Rights, including HIV and AIDS, medical education, and the 2 which I will be presenting today, being the Standing Committee on Professional Exchange and the Standing Committee on Research Exchange. So, as I mentioned, we have 2 different exchange programs, and we work in 130 countries. We also host around 15,000 exchanges each year. So we are a little bit, we are a big deal, let's say. Let's start with the first standing committee, being the SCOPE, so the Standing Committee on Professional Exchange. And here I'm going to talk a little bit about how a professional exchange organized by IFMSA looks like. So the type of exchange that we offer is a 4-week internship at a hospital department. It is available to students after their 3rd year, and it is only available for medical students. However, we have another program, another standing committee on research exchange. It is another exchange program, also for 4 weeks. However, SCORI takes place in a lab or a clinic, and it is available to students after their 1st year. So they can apply to a SCORI exchange when they are on their 1st year. And it is not reserved for medical students because we also welcome students of pre-medical courses, biomedical, and also graduated students. When it comes to SCORI, we offer 4 types of different research programs. This is either basic science, which usually revolves around anatomy or biochemistry. We also offer clinical projects with lab work. So this is a little bit of a combination between the hospital and contact with patient, and also some work in the lab. And we also have a clinical project without lab work, so strictly working with the patient, around the patient, and gathering data, and later coming up with often a scientific article. And we have a global action project, which is a project related to public health. When it comes to the aim of both SCOPE and SCORI, we aim to promote cultural understanding and cooperation amongst medical students and also health professionals through the facilitation of such exchanges. We believe that we offer unique educational and cultural experience in addition to regular medical curriculum. And we also hope to broaden the perspectives of our students in different parts of the world. We have two different types of contracts that our students can apply to. The first one is a bilateral contract. During the bilateral contract, two students are exchanged, but not necessarily at the same time or in the same university. The student going for an exchange pays the bilateral fee on his own student organization, who then uses the money to accept a student from a different country free of charge, and vice versa, to make sure that the students are not limited by their financial resources and have the opportunity to go for an international exchange all around the world, regardless of any burdens. When it comes to the unilateral contract, it is a little bit different. An NMO, which is a national member organization. So, for example, IFMSA-Poland is a separate NMO. The NMO sends or hosts a student without any kind of reciprocity. From the other national member organization, and the student just pays all of the expenses to the host organization. And when it comes to the things that are necessary for the application process, it is crucial to understand how we work in IFMSA. In IFMSA, we work by collecting points during many different volunteering activities. We educate younger students. We educate also people in malls. We organize many different conferences, and this is how IFMSA works. This is how we collect our points, and by a point collection we can receive contracts, because the contracts are assigned according to the following rule, that the person with the highest number of points gets a contract. On top of that, we also value grades, which are always approved by the Dean's Office. We also encourage our students to be active members of scientific clubs, and we also value scientific achievements, and these are also a big part of the application process. When it comes to the costs, because it all sounds amazing, and now it's the time to talk a little bit about the costs. The cost of an exchange, we have three different types of fees that are required to be paid. The first fee is the contract fee. It is a kind of fee that goes to the federation as a fee for the membership. We also have a fee for the incoming student. It is the fee that will be used for accommodation and also for the food for the incoming student. And we also have a return fee, which the cost of return fee varies from local comedy to local comedy. However, it is a fee that can be returned to the student once they take care of an incoming student and become their contact person. So I believe it's a little bit similar to Erasmus, because Erasmus, I believe, has Erasmus buddies. So it is a similar thing. And what is included, let's say, in these costs is the lodging, which is usually a student flat or a student hostel, or sometimes it is a host family. At least one meal per working day, which is usually lunch or dinner, or an equivalent amount of money for that meal. Also, the basic means of comfort related to the living conditions. And of course, what is the most important part is the professional clerkship with access to either preclinical or clinical department, or a research project, research exchange with a research project. However, The fees don't include things such as a visa, a plane ticket, a vaccination, or insurance. This is all on the student, and the student has to cover it. So, if not Europe, go global. We are extremely happy that IFMSA-Poland, as IFMSA-Poland, we are able to offer medical students exchanges to different parts of the world. Each year, we strive to secure the best contracts to the best destinations so that we can enable our students to visit diverse and enriching destinations such as Kenya, Jordan, South Korea, and many, many more. Not only do we send our students to various parts of the world, but we also host around 600 international students annually in Poland. This mutual exchange fosters a vibrant international community and promotes cultural and academic growth. Our exchanges are unique because they are organized by students and for students, and this peer-driven approach ensures that the programs are tailored to the needs and to the interests of our medical students, creating a supportive and I'm sorry, I'm still a little bit sick. Just a second. So sorry. So I believe that this peer-driven approach ensures that the programs will be tailored to the needs of the students. I'm sorry, I have to stop for a second. Okay, I'm trying to share my screen again. Hopefully the screen is visible, sorry.
Yes, everything is okay.
Okay, so for those who already explored Europe and are eager to immerse themselves in different cultures, our exchanges offer a fantastic experience and a fantastic opportunity to experience life on a different continent for a month, sorry. And it's wonderful to see and to know that both IFMSA and Erasmus exchanges are gaining popularity among students. These programs provide invaluable opportunity for young people that are at the very beginning of their careers and want to gain perspective and cultural understanding. And having both Erasmus and IFMSA available allows our students to choose the program that suits best their needs, offering diverse pathways for personal as well as professional development. Thank you so much, and I'm so sorry for the problems. I'm still a little bit sick and coughing. In case you want to get to know a little bit more, I am available via email. It's going to be way easier for me to answer than to talk with my cough. Thank you so much.
Thank you so much for giving us your time despite being a little bit sick still. And I think it will be a valuable addition to our conference that students will know that they have other opportunities except Erasmus as well. Next, we have our following speaker is Professor Didier Leys, a professor of neurology at the University of Lille. We have a focus on stroke, dementia, and cervical artery dissections. He has held leadership roles in neurology societies. He serves as General Secretary of the European Academy of Neurology and contributes to high-impact journals like Lancet and Lancet Neurology. He is the current editor-in-chief of the European Journal of Neurology. Therefore, he will share his insights on publishing a good scientific article. Hello, Professor. And if you want to share your screen, please use the green button on the bottom of the screen.
Thank you very much for this nice introduction. Do you hear me well?
Yes, we can hear you properly.
So I will share my screen. I think you should see it now.
Yes.
Is it correct?
Yes, and please, exactly, and please use the slideshow, and now everything is great.
So it's fine. Thank you very much. I have no special disclosure for this talk, except that I am paid to be editor-in-chief of the European Journal of Neurology, as all editors, I think. So I would like to start with a few tips on what you have to do before you write your manuscript. The first issue is that you have something important to say. We don't publish just for the pleasure to publish and because we need to publish to survive, but also because we have something important to say. You have also to keep in mind what is your key message and what is the message you want to deliver to the audience. And this is also something important. What is not important should be removed. So be as short as possible when you write your article. Before you submit, you have to read carefully the instructions to authors. If you don't follow the instructions to authors, you decrease your chance to be accepted by the journal. And you have also to make the right choice for the journal. For instance, I am a neurologist. I am specialized in stroke. And if I publish, my first question will be, is my message interesting for all neurologists or most neurologists at least? Or is it something which is of interest only for highly specialized stroke neurologists or stroke physicians? And depending on the answer, I will choose the right journal. For instance, if you publish something on the organization of care for stroke patients, this is something which is of interest for all neurologists, or should be of interest for all neurologists. And in this case, it's better to choose a general journal, European Journal of Neurology, JNNP, Journal of Neurology, Neurology, for instance. If your message is a message that is of interest just for those who are highly specialized in stroke, but it's the same for other fields of neurology, for instance, comparison of two devices to perform thrombectomy. This is not of interest for a specialist of Parkinson's disease, for instance. In this case, you should choose a specialized journal. And there is a third category of journals I did not put here because we have fewer manuscripts published in these journals. They are journals of interest for all physicians, all doctors. And for this, you have journals such as New England, Lancet, etc. So the choice of the journal is very important. And as editor of a journal, sometimes I reject articles that will be accepted in journals with an higher impact. And these articles were rejected just because they were too specialized and not for general neurologists. Then you will have to organize your manuscript following these sections. We called it IMRAD for Introduction, Method, Result, and Discussion. And we have had an A here for end because otherwise most people cannot pronounce. Maybe in Poland you can because you sometimes have a lot of consonants in the same word, but it's difficult for other people. This format is something which is rigid, this IMRAD format, and it's important to follow it because we have to communicate in a uniform manner, to follow the same rules to be able to read very quickly a manuscript. This is important because we can read a manuscript at different levels. For instance, we can read just a title, just to find out what is the information available. And sometimes we can stop after the title. If I read, for instance, the New England Journal of Medicine, I will see that the title is, I don't know, a technique for a gynecologist or something like this. I will stop after the title because I have no special interest for that. Sometimes we will read the title and the abstract. For instance, again, I go back to the Lancet or the New England Journal of Medicine. There is paper in a specialty that is not my specialty, pneumology, but for instance, but this is a topic that can be of interest for many people. And this was the case during the COVID pandemic, of course, for instance. And in this case, we can read the title and the abstract and have the message, the main message. Sometimes we go a little bit more deeper. We read the title, abstract, and the results, including tables and figures. And of course, for few manuscripts, because we cannot read all the literature, we will read the whole manuscript. So it's important to follow this rigid structure to be able to read the manuscript at the right level, which is the level you need. The title is very important. It should be specific enough to describe perfectly the content of your article. As editor of a journal, I receive sometimes manuscripts for which, when I have read the title, I cannot understand what is a topic. I suppose it's a topic on neurology, of course, because it's a journal of neurology, but I cannot understand if they speak of multiple sclerosis, of stroke, or neuromuscular disease. And this is not good, because if, of course, I can read the abstract and the article, but if somebody cannot see what is the topic in the title, this article will never be cited and will not be included in reviews, which is a big problem. The title should not be too technical. Sometimes it's too technical and can be understood only by highly specialized people. It should describe the topic, effect of alcohol on seizures after stroke, for instance. It may sometimes summarize the results. Alcohol increases the risk of seizures after stroke. So you already give the answer before you ask the question. And it's important that the title starts with what is important. In this work, for instance, what is important is alcohol and stroke. They are the two important words. So alcohol and stroke should be in the title, of course, and seizures. And here we have make the choice to start with alcohol. And most readers, so this is something you have to bear in mind, most readers will stop after the title, so try to be attractive. And this is important also to have your manuscript reviewed, because one of the problems the editor is facing is to find reviewers. And when we fail to find reviewers, it's usually because the title is not attractive and because the abstract is not attractive. So it's very important to have a good title and a good abstract, of course. The authors, we have to follow a protocol for this. We will not name somebody author just to be nice with a person. There is a definition of authors, and the Vancouver Protocol gives this definition. Authors should be involved in conception and design or analysis and interpretation of data. And they should have contributed in the drafting of the article or the critical review of the article. And they should give a final approval for the version which is published. It's not acceptable that somebody who is author did not see the last version submitted to a journal. Of course, they should agree to be authors. It's a responsibility, and they should have full access to the data before they approve the final version. And if you don't know if one of your colleagues should be author or not, the best way to answer this question is would this person be able to present orally the manuscript and take responsibility of it? Somebody who is author cannot say, I am not able to present this paper at a meeting. If a person is not able to present the paper and to take the responsibility, this person is not an author. Maybe this person has contributed to the work, but there is a place for in the enlargement in this case. We may have a few exceptions, and you will understand easily that there are people who play a crucial role in a specific area and are not necessarily able to present the whole paper. For instance, statisticians, sometimes neuropathologists or radiologists, because they contribute only for a crucial part, but which is just a small part of the article. So we may sometimes explain exceptions. The abstract, it's very important, the abstract. You have to summarize your article in less than 250 words. And this is usually something on which most scientists will be based to decide if they will read the full article or not. For a systematic review, it's usually on the title and abstract that we decide if we will keep the article in the analysis or not. So it's very important, because if the abstract is not good, the risk is that your abstract is excluded from reviews, which is also a pity, even if the article is good, because we cannot read all the literature. The abstract can be published separately in bibliographical sources. PubMed, for instance, you may see the abstract and nothing else. Of course, in the abstract, you give no reference, no figure, no table. And the abstract is usually divided into 4 or 5 parts. It depends on the selection of the authors. You always have to give the objective, which is the last sentence of your introduction. So it's very easy to do. The abstract, you have just to copy the last sentence of your introduction. The objective of our study was to evaluate the influence of alcohol in the seizure after stroke, for instance. Then you have the methodology, the results, and in the abstract, you have no discussion. You have just a conclusion, 2 or 3 lines. Our study has confirmed that. Our study has shown that. Our study failed to show that. Sometimes the abstract is divided into 5 parts, and in this case, they ask usually to add a background, and this is usually the case for non-specialized journals where you have to explain why you did this study, which is not necessary in highly specialized journals. But for this, you have just to look at the instructions to authors. A good strategy to write an abstract is that you write it not at the beginning of your writing, of course, because your abstract at the end will be completely different from your manuscript. Not necessarily when you have completely finished your manuscript, but the good way is to write the corresponding part of your abstract when you have written each corresponding part of your manuscript. When you have finished with the introduction of your manuscript, you can already write the background and the objective in the abstract. When you have finished with the chapter methodology, you can write the corresponding part of your abstract, etc. And my advice would be to start, even if the instructions are abstracts of less than 250 words, you can start with an abstract of 500 or even 750 words. This is not a problem. And at the end, you will reduce the abstract and remove what is not essential. It's always possible to reduce the size of a text. And of course, all information appearing in the abstract should appear in the paper. And this is the reason why you cannot write the abstract before you write the manuscript. The introduction should answer 4 questions. What was the topic of the study? Why was it an important question? Why did we know about this before we started? And what was the objective of your study? It's better to use the active voice. For instance, say we included patients and not patients were included. It's better to start with a keyword. Stroke is, multiple sclerosis is, or often leads to. Be careful that you should not have redundancies between the introduction and the discussion. This is something we see quite frequently. People repeating in the discussion what they said already in the introduction. And you can, of course, use references if this may help you to have a shorter abstract. In the references, reviews are welcome in the introduction. Patients and methods. You should here, the objective is to provide enough information to allow other researchers to reproduce your study. To perform a good study is important, but it's very good if somebody can, in another context, reproduce your study, because this is a way to validate your results. And for this, you have to give as many information as you can to allow other people to use the same methodology. You can use a diagram, a table, a flow chart. Usually we have this famous figure 1, which is a flow chart showing how patients were selected. This is important here. Never provide results in this section. And you have, of course, in the methodology to describe a lot of things, how patients were selected, diagnostic strategy. You have to define everything and give the criteria you used. To explain how patients were treated, how the outcome, the endpoints, were evaluated, and the statistical point and the software used should be also described. If your study was registered, which is the case for prospective studies, you have to give the registration number and, of course, to give a relevant ethical consideration. Was it approved by an ethical committee? Which one, with a number? And did the patients or the relative give a consent, or was a consent considered as non-necessary by the ethical committee, which is sometimes the case for retrospective studies. In the results, you have to be careful not to discuss the results in the results section. You have just to give the results and no comment about it, no explanation, just the results. You have to use the most appropriate method for this to show the data in the smallest space, because journals have space limitations, and you have to choose between text, tables, figures, and the choice is not just by chance, is what can help you giving the result in the shortest volume. Sometimes it's a text, sometimes it's a table, sometimes it's a figure. Tables are important for manuscripts. For oral communication, we will sometimes prefer figures because it's easier for the public. Statistics should be given here. They may appear in the text, but also as footnotes in tables or figures. Don't forget to give important negative results. They are sometimes more important than the positive one. Again, use the active voice and the past tense. And don't forget to give in the statistics the differences, but also the directionality and the magnitude of the effect. For instance, a p-value is not enough. A p-value shows that there is a difference between two groups. Well, it's an information. But the magnitude is important because if you have many, many patients, you may have a significant result, but with a very small magnitude and no interest in practice. And you have to show also if what you studied is more frequent or less frequent in one or the other group. So directionality, magnitude are also important and not just the p-value. The tables and figures, you can use them to provide more details or to provide similar results compared to a text in a shorter way. They should not be redundant with the text. If you say something in the text, you have not to repeat by a table. Tables and figures should have a title don't forget to label the axes in figures, X and Y, and don't use figures. We don't use tables for fun, but don't use figures for fun. I don't like, for instance, when the people want to describe the sex ratio to have a figure. There is no interest to have a figure with a kind of cheese and 2 parts. For sex ratio, you have just to say that women accounted for 55% of patients, or men accounted for 45%, and it's enough. Don't use a figure or a table if you can just provide one sentence. In this case, they are not necessary. And don't forget that a table or I hope it works. If not,
yes, we can hear you properly.
Oh, okay, thank you. Don't forget that a figure or a table should be understandable by their own. So you need to define all abbreviations, even if you defined already in the text or in the abstract. The abstract, the text, the figures, and the tables should be completely independent, and you have to repeat the definition of abbreviations. The discussion should be divided in 5 parts. The first one is just a statement concerning the main finding. Our study has shown that alcohol increases the risk of seizures after stroke. No detail, no p-value, nothing else, just the main finding. And if you want to read very quickly a manuscript, a good way for this is to read first the last sentence of the introduction, which is your objective, and the first sentence of your discussion, which is the main message. We wanted, in the introduction, we wanted to evaluate if alcohol was a promoter of seizures after stroke, and result, we have shown that. Then you will compare your results with other studies, and you will explain differences. We found this, the other one found differently, but maybe it's not the same population and so on. You will discuss the external validity. Our study were performed only in a single center in China and maybe not valid in all other populations, for instance. You have to discuss the possible mechanism and implication for clinicians and policymakers, to discuss the strengths and the limitations. This is very important. And at the end, you will identify what are the unanswered questions and ideas for future research. In the discussion, you should not give new data. And in the discussion, you will write the discussion. My advice is that you have to read again all the sections of your manuscript, and after each section, you put your ideas below these 5 headings, and at the end, you will be able to write easily your discussion. References, I think people younger than me are used to EndNote, EndNote reference managers, Othello, and so on. Don't forget to follow the instructions to authors and call this part references and not bibliography. A bibliography is different. It's more for a book, and you can cite in a bibliography articles you don't cite in your text just to give a bibliography. But this is for books and not really for research and for medicine. Don't forget that you can give extra data also as appendix. For instance, you can give extra figures and tables that are not crucial but interesting, explanations of formulas, full generic names, list of participants and participating centers. They can be somewhere on the web. This is almost my last slide. The cover letter. This is something you will write when you are finished, before you submit. It's a correspondence with the editor. This will not be seen by the reviewers. It's just for the editor. And here you have to explain why your finding is important, what it is, why it is new, because we always prefer to publish new data, why you think the journal is the right one for this publication, not just because your journal is a famous journal, this is not enough, but you chose because your journal is a journal for general neurologists and the message is for all neurologists, for instance. If the manuscript was already rejected by another journals, you can say, and you can even provide the reviews. This may be useful. And don't forget to say anything that the editor should know. People who may have conflict of interest and should not chosen as the reviewers, for instance. In short, the cover letter need to be transparent. If you already published a part of the study, you have to inform, of course, the editor. And a rule, often we have manuscripts rejected and we will submit to another journal. And here it's important to bear in mind that we should not, as author, be paranoid and consider that the editor or the referee does not like you or does not like your job. I think the good message is that the referee and the editors are always right, even where they are not. It was a case here during a football match between Germany and England at the World Cup 2010. The goal was not accepted. I think it was a goal from the English team, but they accepted the mistake of, and they continued, but they lost the match at the end. And don't forget also that differences in languages may explain sometimes statements, even between the two groups of people speaking the same language. Sometimes we do not mean exactly the same thing. And so don't be too sensitive when you read a review. For instance, there is a big difference between English, British, and Dutch. Dutch are very tough, and sometimes you can consider that it's very impolite, but it's not. It's like this. While British will be more friendly, but sometimes say things that are even worse than the Dutch, in other words. So be very careful when you interpret this, and always consider that if you think the editor was wrong, it may be just because you did not properly explain, and try to change. So my take-home message is here very short. Have something important to say. Keep your key message in mind. Remove what is not important. Choose the right journal. Follow the IMRAD presentation. Avoid redundancies between introduction and discussion. This is a frequent mistake. You can use web appendix when needed. Explain what the editor should know in the cover letter and be transparent in the cover letter. And before making a rebuttal, consider that the editor was probably right. I think the only circumstance where it's appropriate to make a rebuttal is, for instance, your manuscript was rejected and you want to make an appeal, is when you consider there was really a mistake. For instance, and this may happen, for instance, if the review you received was not for your article. Sometimes the same reviewer has two articles from the same journal at the same time and send a review to the wrong, for the wrong manuscript. And this may happen. We have the problem approximately once a year. And sometimes the decision is based on a review that was not for this manuscript. In this case, of course, you can make a rebuttal and explain that you are not sure that it was really for your journal. And sometimes the editor will change his decision. So thank you very much. It was a bit short, but I will leave you my slides if you want. Thank you.
Yes, that would be great. Thank you, Professor Ley, for this presentation. I am sure that most of the students, definitely I will be using those tips because this is something that we don't know once we submit articles to journals. So this was very valuable. And I thank you again for your time. That is also so valuable. So thank you and enjoy your day.
Thank you very much.
And up next, we will have some quiz on Kahoot. Before we begin, I would like to extend a thank you to our patrons, the Minister of Health, Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, the Rector of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, as well as the Student Government Association of the Medical University of Silesia. I would also like to express our gratitude for the sponsor of the quiz, which is Compendium Medicine, Corpus Mind, Eldon, MedAntlers, Medycyna Praktyczna, PZWL, and Więcej niż Lek. So now for the rules of the quiz. To participate, please take your phone and enter kahoot.it. Now I will be sharing the screen. Then click play. A window will appear where you can insert the code, which will be shared with you in the transmission. You should be able to see it right now. After you insert the code, the game will ask you to generate a nickname, which will be your representation throughout this game. In this quiz, there are 20 multiple choice questions. Your phones will show you the buttons and colors matching the answers on the screen. You will also be able to see the question on your own screen. You have to answer not only correctly, but also quickly because both measures are equally important to win. After each question, the current score table will be displayed. And don't worry if you do not end up in the top right away, the ranking usually changes multiple times throughout the game. The winners of the first 3 places will receive a prize. This will be a surprise. And we ask you to contact us by email, sending a screenshot that confirms that you are the winner. I hope that those rules are clear. And now we'll wait for some more to join and we will begin shortly. Here we can see the results. Congratulations to the winners of the quiz. Congratulations to the winner of the quiz. Please contact us via email to give your result. Moving on, we have Professor Elisa Jimenez-Cabré from the San Pablo CEU University presenting on giant vesicles, a powerful tool to reconstruct cell events, a bottom-up synthetic biology point of view. Here, Professor Jimenez, please share your screen by the green button on the bottom of the Zoom call.
Hello, everyone. Can you listen to me?
Yes, everything is visible and we can hear you as well.
Okay, thank you very much. So it's a very, very nice pleasure to be here sharing with you all the work that I performed some years ago here in Madrid. So very nice greetings from CEU San Pablo University here in Madrid. So the research that I'm going to show you is regarding some different stuff that maybe you are not very familiarized. So I will do my best to do it in a very, very naive way. Okay. So my presentation is entitled "Giant Vesicles: A Powerful Tool to Reconstruct Cell Events, a Bottom-up Synthetic Biology Point of View." So I wish and you enjoy my presentation. Here it comes. There are 3 different points in which about what is going to be my presentation. I'm going to make a short introduction of what is synthetic biology and what is a bottom-up point of view. The bacterial cell division process, which is the process in which we are interested in, and how we build these synthetic environments, because we build these synthetic environments in giant liposomes, and we want to confine and we want to reproduce the different processes that happen in the cell. And these giant liposomes are going to be performed with the droplet transfer method. And we will entrap 2 different proteins, and we will test the different events and how they interact to these 2 proteins, which are called FTZ and cTa. Finally, I will give you a short glance of some results, some fluorescence microscopy results that they are already published, and the advantages. And I would like to make a discussion of the advantages of this transfer method, that I find it very useful, especially for drug delivery. So what is synthetic biology? Synthetic biology has lots of definitions, and this one is the one that I like the most, and it's quite complex. So it is a biomimetic chemistry, and it recapitulates the behavior of parts of the biology. So what we do is to try to reproduce cell events inside a test tube, but we want to work in a test tube in a higher complexity, because we are going to work with a biomimetic system. So we are going to take different parts of these non-living components, and we want to reproduce these living systems. That's why we call it bottom-up approach. So these confined containers are going to be called biomimetic systems, and we normally call giant unilamellar vesicles. I will refer in this presentation as GAPs or giant unilamellar liposomes. So what we want is to be in between the dilute solutions that we lose a lot of experimental and biological relevance, but we gain control if we work in a cytomimetic media. Of course, we lose some of uncontrolled pleiotropic effects that happened in the living cell, but at least we gain control. and we are not so far away from the living cell. So we work in between. And our cytomimetic media, in which we can find crowding effects that really happened in the cell, is going to be inside these unilamellar vesicles. So what do we need if we want to generate a cytomimetic media? So first, let's look to our checklist. The system of study is the bacterial cell division. Then we have to look for the protein of interest. It is not the same working with a soluble protein or a membrane protein. This membrane protein, normally it's hard or difficult, it's challenging to purify it. And finally, the confined container. So imagine that our confined container is going to be like our cell, okay? Because it is going to be a liposome, it is going to be covered of lipids. So our system, let's make a short introduction of our system. The system is the starting point of bacterial cell division. So that's why we want to test how hs-cT and cPay, which are the two main proteins that start cell division, the bacterial cell division. Of course, there are 8 extra proteins that generate the complete division. But the one that leads the bacterial cell division is hs-cT, that you can find it here. So how behaves this hs-cT? When the cell is not going to be divided, it stays as a monomer. But at the signal that when the cell is prepared to be divided, the hs-cT generates this ring, and this ring is going to call for the extra protein. So this ring is going to be a scaffold for extra protein interactions, but if there is no ring, there won't be any kind of division. So in this point, we are very, very interested on how it is generated. So some signals like extra GTP generates these filaments, and these filaments interact with each other, creating a macromolecular complex called bundles. And if we don't feed extra GTP, this hs-cT is going to be disassembled and stay soluble. So you can imagine here, hs-cT can grow and call for the extra proteins, and what it does is to create pushing forces in order to generate the septum formation, and then creating the 2 new cells with their own membrane. So let's see. So if you have already more or less understood this system, I will show you a small cartoon in a very nice way for you to understand. Here you can see cPay, which is the other protein that we are interested in, and hs-cT that stays soluble outside the membrane. It stays soluble in the cytoplasm. So GTP is added, and hs-cT is polymerized, and it interacts with cPay. So we wanted to test if we are able to reproduce these forces, these constriction forces that are generated in the septum. So let's go for our checklist. We have to purify hs-cT and cPay, and we did it with the typical recombinant expression systems, and it had different strategies because they have different physical-chemical properties, of course. Then, as we wanted to test the presence of this hs-cT and cPay, we labeled them with fluorescence proof. In this presentation, hs-cT is always going to be in green, and cPay is going to be always in red, for you to understand and for being clear. And finally, we want to test the behavior of these 2 proteins inside the cytomimetic system. This cytomimetic system are going to be done with the droplet transfer method. Finally, these vesicles are going to be analyzed and tested through confocal fluorescence microscopy. So let's see how we build our cytomimetic system, because it is kind of tricky, but I hope you understand. Here, you can see, and you can imagine that you are inside, you can dive inside an ependorf. So we can generate a preformed monolayer in between two different phases, the oily phase and the outer phase, that is going to be the outer phase in which are going to be floating on our vesicles. And the oily phase is fully saturated with lipids. So what we make is some small droplets full of the protein that we want to encapsulate, and these droplets are going to travel through the oily bulk phase, and these vesicles are these droplets are going to be covered by one hemilayer of lipids. And this we normally call these structures inverted micelles. This inverted micelle has to cross the already preformed monolayer that is waiting in the interface of the aqueous and the oily phase. And as it crosses, it is going to be fully covered of lipids. So now we have the complete liposome with the protein inside the liposome. And what we want is to test if the protein inside this capsule works at all. So our strategy was to insert a pore-forming protein that is able to generate pores in the membrane, and in this way we were able to trigger the hs-cT polymerization. So it's a very, very nice way to test if the enzyme is working at all, these GTPase. So here you can see a cartoon. Let's see, we are able to encapsulate. Then let's see if hs-cT is working inside our vesicles or liposomes. So here you have a real result, a confocal microscopy fluorescence result, in which you can see a giant vesicle that contains the hs-cT in green. And in this case, it's red, the cover, which are the lipids that are already labeled with a fluorescence red label. Then we waited, we added alpha hemolysin. Remember, this is the pore-forming protein, and we added the two cofactors, the cofactor that this protein needs, and of course, the substrate that is the GTP. And we obtained this giant vesicle harboring this very, very nice polymers framework. So we wanted to jump a step further. So now we added the cPA protein. Remember, this cPA protein is attached to the membrane. And now that's why you see these membranes in red. Here you can see a time lapse in which there are different pictures in different times in which you can see that we trigger the hs-cT polymerization, and the membrane cover changes the color because the hs-cT interacts with the membrane. So hopefully, of course, we know that the protein hs-cT interacts with cPA. Look at this. I want you to focus on the concentration because we are going to use a higher concentration in the next slide. But here I want to show you this nice video of how we polymerize, how we trigger the hs-cT polymerization, and how the membrane becomes yellow because of the colocalization of both proteins. So using higher concentration of cPA attached to the membrane, because we know, all of you that know that protein concentration matters. And in this case, the protein concentration is very close to the physiological one. So it's very important. So what we saw is that we were able to create the polymers. The polymers were triggered, but something strange happened. it wasn't too strange because it was what we wanted to see. So we saw that vesicles are able to collapse. So you can see in the video below how they go smaller. So we were able to generate these forces that go towards the vesicle. In order to study in a better way and in a better understanding of how this protein interact, what we added an GTP analog, which is hydrolyzed in a very, very slow way, because we wanted to see how were these forces that generate the FTS-cT. And as you can see, in a very long times, you can see in green FTS-cT, it polymerized and it goes to the membrane, and then the vesicle surface ruffles itself. So we can see that this engine is working very well, but they work in an isotropic way because it goes to the center of the vesicle. In a further step, we wanted to test if we were able to detect an inhibition of one peptide that we are going to call it hs-cTn. This peptide is supposed to inhibit the interaction between FTS-cT and cPA. So, as you can see here, this is the typical FTS-cT framework with in a stack projection of the confocal, and it interacts, of course, with the cPA of the vesicle, and there is no shrinking. That is shrinking that we were able to see. But we wanted to check further analysis. So the integrity of the vesicles in presence of this inhibitor. So we are inhibiting the interaction of these two proteins. So in this way, we will be able to inhibit cell division. So it would be a very good candidate to test further antibiotics effects. In order to see if it really works, what we did, we played with the different conditions, and what we did in this case is cPA is not going to be anchored to the membrane. So that's why you can see in the green channel FTS-cT, in the red channel you can see cPA, and in the yellow channel you can see the colocalization of both proteins. Without inhibitor, if we trigger the polymerization, you can find the green FTS-cT, but at the same time, the cPA goes towards these polymers. So it means that there is some kind of interaction. These assays have been already tested with fluorescence correlation spectroscopy as well. And if we added the inhibitor, there is no red polymers because there is no interaction. So we find that this is a very good candidate with different targets from the antibiotics that the normal antibiotics do. And here you can see a very long video in which we take some pictures in which you can see that the FTS-cT frameworks stay for a very long time in presence of this antibiotic. And finally, I would like you to show that this droplet transfer method, it has a very high efficiency in vesicle formation, and it has a very homogeneous size at the same time. In a very short period of time, you can obtain a very good quality of sample, and you can entrap in this kind of vesicles any kind of protein or drug, and there is no hazard conditions for them. At the same time, we are going to preserve this protein activity. At least we show here that we have an active protein. And the funny thing is that you can use different compositions from outside and inside, always, of course, maintaining the molarity or in between the intra and extra vesicle buffers. And another very nice thing is that we can use compositional asymmetry in the membrane, so you can have different hemi layers, and that's why we can. I find that it's a very good technique and a versatile technique for drug delivery. And that's all. And thank you very much for listening.
Thank you, Professor Jimenez. This was a very interesting presentation, and I am sure that the viewers will benefit from listening to this research, especially because most of medical students focus on the clinical part of medicine and not the preclinical, which is also as much important as the clinical part. So thank you again for giving us your time and sharing this knowledge.
It's a pleasure. Thank you very much for inviting me.
Thank you very much, and have a nice day.
You too.
Now our next speaker is Professor Leonidas Phylactou, the Chief Executive Officer and Medical Director of the Cyprus Institute of Neurology and Genetics. He will be talking about his research work from Molecular Function and Therapy Group, of which he is the leader, and that is conducted at the Cyprus Institute of Neurology and Genetics. Professor Phylactou, if you may please unmute, open the camera and share your screen by the green button on the bottom of the Zoom call. Okay, hello, Professor Phylactou, can you hear us? Okay, we are having some technical difficulties, maybe from one side, so we'll wait a little bit. And after Professor Phylactou, we will be listening to one more speaker, and then we'll have two more quizzes and a longer lunch break. So now we are just waiting for Professor Phylactou to join us. So while we wait, I would like to thank our sponsors and patrons once again for helping us develop this conference. So I would like to extend a thank you to the Minister of Health, Izabela Leszczyna, the Śląska Izba Lekarska, IFMSA-Poland, the Rector of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, the Student Government Association of the Medical University of Silesia, and our sponsor of the quiz prizes, which is Compendium Medicine, Corpus Mind, Eldon, Medantlers, Medycyna Praktyczna, PZWL, and Więcej niż lek. Now I can see that Professor Phylactou has joined in. If you may please share your presentation on Zoom, and we will begin to listen to your research in Cyprus.
Hello, and thank you for inviting me. Just bear 1 second to upload my presentation. Okay, can you see that now?
Yes, we can see and hear everything clearly.
Very well, thank you. So, a pleasure to be with you today and share some of our research experiences. I chose one of the topics that we are dealing with and we have dealt for some time now, and I will guide you through. The topic is microRNAs as biomarkers for myotonic dystrophy type 1. So just to give you a very brief overview of what we do in our lab, this is a project that will describe microRNAs as biomarkers for myotonic dystrophy type 1. We also work on the microRNA tissue communication, the way that microRNAs travel and communicate between tissues. Finally, the development of EVs, extracellular vesicles, as therapeutic vehicles for delivering therapeutic materials into muscle, which is going to be applicable for muscle diseases. So, as I said, we'll start with the project that we'll go through today. But first of all, let me just say a few things about some basic concepts, like, for example, what is myotonic dystrophy? Now, myotonic dystrophy basically is one of several diseases which are called muscular dystrophies. The common characteristics of these muscular dystrophies is, first of all, they are inherited. So they are caused due to mutations in genes. And secondly, they have a common theme of muscle weakness and wasting. This is a main characteristic of patients that have muscular dystrophies. Now, a little bit more about myotonic dystrophy. So what is myotonic dystrophy? It's the most common of all these muscular dystrophies in adults, meaning that it usually manifests during adult life. And it's the most common form that manifests in the adulthood. Approximately 1 in 8,000 individuals globally. This is the incidence of the disease. And how is it caused? It's caused by an expansion at the 3' UTR of the gene called myotonic dystrophy protein kinase, DMPK for short. And this is an expansion of a cTn repeat. This repeat usually appears to be in the area of no more than 50 repeats in the 3' UTR of this gene. And in the case of patients, it may go up to a few thousands. Now, it is an autosomal dominant inherited disorder, meaning that you only need one of the 2 copies to be mutated to exhibit the disease. And the disease is experiencing the so-called genetic anticipation, meaning that the disease usually gets worse in successive generations. Now, although this is not the topic of today's talk, the major problem in the myotonic dystrophy, as you saw, is in the 3' UTR because of the expansion, which means that the problem is not carried over to the protein. So it's an RNA disease, basically. And the main characteristic is that this expanded cTg repeat in the 3' UTR of the gene makes at the RNA level huge hairpins because of the structure, which attracts RNA binding proteins. And these RNA binding proteins that used to do something, usually splicing of other RNAs, are inactive because they're bound by these hairpins caused by this mutation at the 3' UTR. And the topic is still under investigation. There is a lot of work that is being done at this area. So, as I said, the topic of today's talk is about biomarkers. Now, what is the definition of a biomarker? What biomarkers are? Biological molecules that give a sign of normal or abnormal process or of a condition or a disease. Basically, it's a marker. It shows something, it's a sign. Now, this is a diagram that I have taken from one of our reviews, and it shows basically the different stages that biomarkers can be useful. Of course, it can be used for diagnostic, that's therefore called diagnostic biomarkers. They can be used for prognosis of a disease. These are called prognostic biomarkers. They can be used for monitoring the disease, especially if the disease is progressive. So this is the so-called monitoring biomarkers. And of course, they can be used to monitor therapies, markers for therapies. Now, what sort of molecules in the blood and why in the blood? Is it in the blood because it's the most accessible place to take samples from a patient. Now, what sort of molecules can serve as biomarkers? Pretty much everything. It could be a protein, it could be a DNA, RNA, a small RNA, extracellular vesicles recently. This is an area that we're interested as well. Proteins, metabolites, and so forth. So our idea a few years back was to look into the blood of patients with myotonic dystrophy and see whether there are such changes in microRNAs that reflect and associate with the disease. Now, I said at the beginning that the myotonic dystrophy, like all muscular dystrophies, patients experience muscle weakness and wasting, meaning that it's a degenerative disease. So patients usually get worse. In the characteristic in myotonic dystrophy is that this deterioration is not the same for everybody. Therefore, there is a heterogeneity in how every patient is progressing. And therefore, the use of biomarkers is quite important and useful. So our idea was to check in the blood of patients for the presence of microRNAs and actually look for the presence of altered levels of microRNAs and see whether this associate with the disease. Our theory was based on the fact that perhaps because of the deteriorating muscle, there could be material that leaks into the blood circulation. And therefore, the first step that we follow was to see whether some microRNAs, which are mainly expressed in the muscles, have increased levels in the blood because of this. So what we do first was to collect samples for patients and extracted the genetic material, the small RNA material, and then we went and checked particularly for microRNAs that we know that they have good expression in the muscle. And as you can see, the first data that we have here is that the DM1 patients have increased level of all these 4 microRNAs compared to the healthy individuals. So this was the first sign that we got that microRNAs are elevated. What we wanted to see next was, since we have different categories of myotonic dystrophies, as I said, we separated the group of patients into patients that they had a stable condition versus patients that had a progressive mode. They were getting worse. And we did see a difference between these two groups as well. So not only there was a difference between healthy and DM1 patients overall, but there was also difference between progressive patients and non-progressive patients. So this was another sign that these 4 microRNAs associate with the disease, but especially with the progression of the disease. The next question we went to see, which was a little bit, as a parenthesis, we wanted to see where are these microRNAs present in the blood? Because there's some microRNAs, and usually microRNAs are highly degradable, and they shouldn't actually stay for a long time and therefore reflect the status of the disease. And we checked in many places. One of the places that we wanted to check was in the whether these microRNAs were encapsulated within extracellular vesicles. So we looked into the extracellular vesicles in the blood to see whether these microRNAs are located there. Now, what are the extracellular vesicles? Extracellular vesicles are vesicles that usually arise from the cells, but they're outside them. They go outside the cells. They are separated between macrovesicles and exosomes, smaller extracellular vesicles. And at the end of the day, they could go from one tissue to another. Definitely, they are circulating within the blood. So we extracted these extracellular vesicles. We extracted the small RNAs from there. These are some data showing these EVs. This is with electron microscope, showing the presence of these EVs within the range that we expected them. This is immunogold labeling with antibodies against EVs. And as you see, they're labeled on the surface of these EVs. And these are molecular markers basically that light up small EVs. And you can see them here as well. So therefore, we did pretty much the same exercise. We measured the levels of these 4 microRNAs coming out of the EV, not from the whole blood. And we saw a similar pattern. We saw a difference between healthy and DM1 patients in all 4 microRNAs. These 4 microRNAs were higher, the levels of, in the DM1 patients compared to the control. And we saw exactly the same thing when we separated into the 2 categories. These 4 microRNA levels were higher compared in progressive patients compared to stable patients. So this was a good proof to us that perhaps these microRNAs are present in extracellular vesicles. Now, the next thing we wanted to do is to monitor the progress in DM1 of these 4 microRNAs. So how did we do this? Basically, we got samples from biobanks mainly at different levels of the disease. In other words, historically, these were samples taken from the same patients at different stages. So visit A, visit B, visit C of the patient, 1 year apart. And we had these samples. We extracted the microRNAs from there. And again, we categorize the patients to stable DM1 patients. And as you can see, visit A and visit B, the levels were the same, meaning that the same patient, different samples from the same patient gave the same levels of the 4 microRNAs, giving us the message that, and based on the previous data I have presented, that these levels don't change between visits, perhaps because the disease is stable. So that was the first sign of having a biomarker that associates with the disease. We then examined the second category of patients, the progressive. And as you can see, there is we found a difference in the levels, higher, like I have showed you before, of all 4 microRNAs between the visits. And therefore, again, concluding that the levels of microRNAs associate with the severity because these patients were progressing and therefore the levels go in hand higher than before. We did other subcategories. So we took from the same patients, we took patients that we knew they were stable. So that was visit B based on visit A. And then we checked them what happened in visit C. Those patients that were stable and they stayed stable, as you can see, the levels remained the same. Patients that they were progressive before in visit 1, but then they became stable, again, they have stable levels. Now, those patients that they were stable, in visit A, and then they became progressive between the two visits, second and third, you can see that the levels of microRNAs were quite higher compared to the stage before. And progressive that continue to be progressive, that always continue to get worse, again, the levels were higher in the last stage. So all this data, again, prove the same thing, that the levels of these 4 microRNAs associate with the progression of the disease. Now, some other graphs, I will just go them through quickly. These are individual patients, just to see how the levels go. Stable patients that remain stable, stable patients who became progressive, progressive patients who became stable, remain similar, the same, progressive patients who remain progressive. There's an upward trend. And some more graphs here. That's log on the log scale. This first column here, progressive, that remained progressive. Excuse me, the row here, progressive that then became stable, stable that then became progressive, and stable that then became, that remained stable. So this again proves the pattern that I have discussed just right now. Now the last bit of the talk, which is something that is underway, is the $1 million question. Can microRNAs predict the disease, prognose DM1? In other words, can changes in the levels of microRNAs can tell us whether the disease will get worse? So to do that, again, we took the patient samples. And as you can see, some microRNAs behave like this. I didn't put any numbers on this because these are still under investigation. They haven't been published yet. But you can see that the same microRNA called A here had the stable who remained stable, whereas stable who became progressive, the levels were higher from the beginning. Okay, so there was a difference. Same with the microRNA B. There was stable who remained stable. That was at the beginning the measurement, and the measurement at the beginning of those stable who became progressive was higher. And the same goes with C. So you see that we're now reaching a stage where we can identify microRNAs. These are not the same as the other microRNAs. What I didn't mention is that we now detected other microRNAs in the blood by RNA sequencing, whereas the first part of the talk was only for 4 particular microRNAs. All this investigation came from RNA sequencing after sequencing all the microRNAs basically that exist in the blood of patients. Now, conclusions from this talk. It is possible to assume that microRNAs can be reliable biomarkers for DM1. More work, of course, is needed for this. It is important to say that we have identified these microRNAs that are carried in extracellular vesicles. And that can be actually a topic on its own for investigating this as part of the pathogenesis of the disease. And thirdly, as I said, these microRNAs could actually develop as biomarkers not only for associating, for monitoring, but also for prognosis of the disease, hopefully. These are just some of my collaborators here, the people in my lab who have cooperation with people from the bioinformatics department at CANG. Several clinicians have helped us throughout this, biostatisticians, bioengineers, especially with the EVs. And this is a picture of my team. Some of them are working on this project, especially Christia and Andre. And this is the institute that we're working. The Cyprus Institute of Neurology and Genetics. Thank you.
Thank you, Professor Phylactou. This was very interesting to hear. What I would like to remind our viewers is that the Cyprus Institute of Neurology and Genetics is also a participant of the Erasmus program. So if someone is interested, then I think that they might be able to reach out, and next year in the next recruitment, reach out to the Cyprus Institute of Neurology and Genetics and have a hands-on experience on the research that you are currently doing there. So thank you again for joining us and letting us know what the molecular function therapy group is working on, and enjoy your day.
Thank you, you too. Nice seeing you.
Up next is Professor Alexander Springer, a European specialist in pediatric urology from the Medical University of Vienna, with a presentation on neurogenic bladder. So, Professor Springer, if you may turn on your camera and share your screen by the green button on the bottom of the Zoom call, then we will be starting.
Hi.
Hello, can you start your video as well? Because we had to turn it off for the transmission purposes. So if you can turn it on back again, that would be great. Okay, thank you. Now we both hear you and see you.
Nice to see you. Can you hear me?
Yes, we can hear you. We can see the presentation and we can see you as well.
Wonderful. That's great. Hello, my name is Alexander Springer. I'm a pediatric urologist. A pediatric urologist is a urologist who takes care of children with urological problems. I am living and I am working in Vienna, in Austria, a very nice place to be. And I say hi to everybody wherever you are. Let me start. Well, the previous talk has been very, very scientific. I want to keep it basic and clinical. I want to start off with what is continence? Continence is the filling of the bladder with adequate amount of urine, the storage of urine without any accidents, without any involuntary loss, a complete emptying, and an emptying at will. When the individuals says, well, I need to go to the bathroom, emptying at will. Parents often ask, how much urine does my child have? There is a formula, 30 times the age of the child in years plus 30 equals the volume. So for example, a 3-year-old child, it's 30 times 3 plus 30, so roughly 120 mils bladder capacity. From developmental point of view, continence starts with the bowels during nighttime. It is followed by continence for urine during daytime, followed by the bowels during daytime. The last thing to evolve is the bladder, the urine during night times. Usually continence happens between 2 and 4 years. We call it non-physiological or even pathological beyond 5 years of age. Probably you are aware of bedwetting, loss of urine, involuntary loss of urine during nighttime, which is very, very common, but should be regarded as a problem only beyond 5 years of age. Continence is a very complex mechanism. I don't want to go into details. I just want to show you this picture. Professor Paprocka is here. She's the host. and she's a neurologist. Therefore, I wouldn't dare to talk about nerves. Neurogenic bladder, the topic of my talk. Neurogenic bladder dysfunction or neuropathic bladder refers to urinary bladder problems due to a disease or injury of central nervous system, peripheral nerves, which is involved in the control of urination. This might be an accident of the spinal cord or the spine, tumors of the spine or near the spine, or other congenital malformations involving the bladder, the spine, the bowels, the nerve, the muscles. The most common congenital malformation associated with urinary incontinence is the spina bifida, myelomeningocele. It is the incomplete closing of the spine and the membranes around the spinal cord during early embryological development during pregnancy. It is basically one of the most congenital malformations at all. It can be due, or in most of the cases, it's due to a deficiency of folic acid. Therefore, pregnant women today receive folic acid, which lowers the probability of spina bifida significantly. Therefore, it's rare in the Western world today. On the other hand, prenatal diagnosis is so high that abortion rate in the Western world is high. There is fetal treatment available. And again, our host, Professor Paprocka from Katowice, she's in the group that does fetoscopic myelomeningocele repair in Katowice, which is a very, very promising new tool available to help children with spina bifida. Spina bifida is associated with many, many different things. Neurological problems, hydrocephalus, orthopedic problems. Some children are wheelchair bound. There's a major issue if incontinence, bowel incontinence, and urinary continence, and chronic renal failure in the long run. Therefore, you see a patient with spina bifida needs interdisciplinary, multidisciplinary treatment, beginning from the prenatal care, the neurosurgery postpartally, the neurological care, urology care, bowel care, orthopedics, nurse specialists, psychological support, social support, and peer support to help the family, to help the peer group, and the transition into adulthood. It needs multidisciplinary and interdisciplinary long-term management. Today, I am talking about the urological point of view in patients with neurogenic bladder. The bladder itself, the detrusor muscle, a smooth muscle, is responsible for storage of the urine. When the detrusor is contracting, the bladder empties. The opponent is the urinary sphincter within the pelvic floor muscles. Contraction of these muscles cause bladder filling and continence, whereas the relaxation leads to emptying of the bladder, something which sounds quite easy to understand, and the simple procedure in reality is a complex mechanism involving muscles, nerves, the central nervous system, and many, many other components, very difficult to explain. From the urological point of view, there is the detrusor and the sphincter. These are the opponents. There are some higher risk constellations where the sphincter is overactive, where the sphincter is not opening adequately. This causes problems of bladder emptying. This causes high pressure in the bladder. This causes long-term problems, and we urgently try to avoid such settings. However, from the patient point of view, an overactive or normal active urethral sphincter is not a bad thing, because it causes continence. And from the quality of life point of view, the most important thing for the patient is to be continent, to be independent of diapers. However, from the safety point of view, the overactive sphincter is a problem. Here are some X-ray pictures where you see patients with severe neuropathic bladder. This is the bladder, which is filled by a contrast media, followed by X-ray. You see that the bladder is now full. It's not a big bladder, and you see the bladder wall is not nicely delineated, but it's full of diverticula and those rough lines. What you see here is reflux. This is backwash of urine back to the kidneys. In the long run, this causes damage to the kidneys, chronic renal failure, and recurrent urinary tract infection. Another picture where you see a bladder that does not look nice, with high-grade reflux and a massively bloated kidney hydronephrosis, as we call it, which in the long run causes severe problems. You don't have to be a urologist to see that this is highly pathological, with a small bladder and bilateral reflux, dilated ureters, and high-grade hydronephrosis, which ultimately will lead to chronic renal failure if not treated adequately. This is another example. This time it's not an X-ray, it is an MRI, magnetic resonance imaging, with a special focus on the urinary tract, where you see high-grade reflux, both kidneys, and high-grade hydronephrosis. This is another test which is frequently used in neuropathic bladder. We call it a urodynamic testing, video urodynamic testing. I don't want to go into details. Basically, what you do in this test is you try to measure the bladder pressure, the pressure within the bladder. The higher the pressure, the less advantage for the patients, and the higher the bladder, the more likely that there are problems. Usually, the bladder is completely relaxed and there's hardly any pressure in the bladder. You see this line here, you see recurrent spikes of high pressure. This is when the bladder muscle involuntarily contracts. This high pressure is measured here, for example, it's nearly 100 centimeters H2O, which is way too high for a healthy bladder. If you see something like this, it's highly, highly suspicious for neurogenic bladder and needs treatment. The management of neuropathic bladder is very complex. It follows multimodality and is highly individualized. Hardly any patient is like the other patient. You have to acknowledge that treatment of neuropathic bladder is long-term treatment. And for the majority of the patients, it means lifelong treatment. Something which comes into focus more and more is the so-called transition. Transition means the transition of the patient from pediatric care into adult medicine. Depending on local settings, on national health care, it's different. In our country here in Austria, pediatric services treat patients until 18 years of age. Then they need to have a transition into adult medicine. Reality somewhat is sometimes very much different. It's not easy to bring these patients into adult medical care. Sometimes it's very traumatizing for the patients to leave the safe space of pediatric care, but it has to be done at some point. And we're trying to build up networks where the patient is then safely transferred into adult care. The basic goal for management of neurogenic bladder is a good quality of life, is a good renal function, is to avoid chronic renal failure, dialysis, renal transplantation, and so on and so forth, and also to reach continence, to get the patients off diapers, to take part in a normal everyday life. The management itself is, again, complex and individualized. There is medical treatment. There's a drug called Botox, botulinum toxin. It's used in cosmetic surgery to have faces look nicer, but we also use it in urology to relax the bladder muscle and inject Botox in severe cases or in cases where medical treatment is failing. There is several surgical treatments, major operations, major surgical reconstruction, but I don't want to go into details. The most important and most frequently used approach in neurogenic bladder is the so-called clean intermittent catheterization. This is when a patient is not able to adequately empty his or her bladder. The patient needs to insert a bladder catheter every 3 hours to adequately empty the bladder, again, for a very long term or even lifelong treatment. It becomes normal life as healthy individuals go to the bathroom every 3 hours. A patient with neuropathic bladder empties his or her bladder using a clean intermittent catheterization throughout his or her life. I am closing my talk about neurogenic bladder. It was just a very brief and rough overview, but I want to show again the fate of children, of individuals born with severe congenital malformations. There are life events, there are phases through a lifetime where things change rapidly, where the problems change, and where every individual needs every support he or her can get. In infancy, it's basically survival. It is how to primarily manage big medical problems. It's the growth, it's the thriving of the patients, and it's the family. Sometimes for young parents might be very traumatizing and very challenging and life-changing to have a child with, for example, spina bifida or neurogenic bladder. When the child gets older, the problems change. There is kindergarten, there is school, there is friends, there's family, there are siblings. When children become older, there's the age of adolescence. Puberty itself sometimes is quite difficult. Now imagine puberty with a medical condition. Things change. The adolescent individual strives to independency. There's the peer group, there is sexuality, there is school. Everything is very changing. And then there is the transition into adulthood, where again, completely different problems arrive. The career, the job, the romantic relationships, the family, having a family on her own or on his own. Major challenges for everybody, for the individual, for the family, for society, for medical caregivers, and so on. With this slide, I will end my talk and say thank you very much for your attendance.
Thank you, Professor Springer. This was a very interesting presentation. I am happy that you decided to show us some images as well to interest us a little more and not talk about only theory. So this was very great, and I thank you for your time, and I hope to see you in future editions of our conference, maybe.
Thank you very much indeed. Thanks.
Thank you very much, and enjoy your day.
Thank you. Bye-bye.
Bye. Okay, now again, it is time to test our knowledge with an interactive quiz on Kahoot. To participate, please take your phone and enter the website Kahoot IT, then click play. I'll share my screen with the code for the game. There are 9 multiple questions in this quiz. Your phones will show you the buttons in colors matching the answers on your screen. You have to answer not only correctly, but also quickly. And again, after each question, the current score table will be displayed. And don't worry if you do not end up in the top right away, because the ranking usually changes multiple times. The winners of the first 3 places will receive a prize. We ask you to contact us by email, and a big reminder to send a screenshot that confirms that you are the winner. So take a screenshot of your nickname or at the end of the quiz. And so now you can join in and we will begin the quiz shortly. Okay, I think we will begin the quiz. So good luck to all of the participants. So we can clearly see 2 people are at the top. Now for the next question. Okay, time is running out. So now 3 people have shown their knowledge on the Glasgow Coma Scale. Now for the next question. Okay, we can see that one person has 3 correct answers in a row. Congratulations. Now for the next question. Okay, here is an update on the leaderboard. So blue is a true and red is false. Okay, Promienny Żółw has 5 correct answers in a row, so on a roll. Now for the next question. Okay, we are now reaching the last 3 questions on the quiz. Congratulations, nearly everyone got their answer here correct. So let's look at the leaderboard. And for the next question, this again will be a question with an image, so read quickly. Okay, we are now reaching the final questions. Okay, this was a difficult question. As you can see, only one person got the answer correct. And so here is the leaderboard. We can congratulate Promienny Żółw Zdecydowany Maskonur and Epic Goose, please take a screenshot of the screen showing that this is your nickname and send an email that you can see in the comment section of our chat on the transmission. Now we are going to have a short break, about 10 minutes, and we will begin our next quiz. So the scheduled break is until 12:15.
Na myśl o studiowaniu medycyny lub wykonywaniu zawodu lekarza często rodzą się w nas wątpliwości. Z czego i jak się uczyć? Jak zdobyć praktyczną wiedzę? Gdzie szukać wsparcia innych? Wyobraź sobie miejsce, które dostosuje się do Twoich aktualnych potrzeb edukacyjnych. Miejsce, w którym możesz zadać każde pytanie i uzyskać odpowiedź. Miejsce pełne atrakcyjnych i praktycznych materiałów edukacyjnych, które same się aktualizują. Tym miejscem jest portal Więcej niż Lek. Znajdziesz na nim kursy e-learningowe, stworzone tak, aby umożliwić Ci efektywną naukę w atmosferze wzajemnego wsparcia, rozwoju, zadawania pytań i uzyskiwania odpowiedzi. Koniec z wertowaniem podręczników przepełnionych litym tekstem czy korzystaniem z nieaktualnych materiałów. Już dziś dołącz do wirtualnych pokojów nauki, dzięki którym wspólnie z innymi będziesz efektywnie uczyć się z materiałów edukacyjnych dostosowanych do Twojego etapu rozwoju zawodowego, podczas studiów, przygotowania do egzaminów końcowych czy w pracy lekarza. Więcej niż Lek to medyczny portal edukacyjny, wspierający efektywną naukę medyków oraz pomagający im w świadomym budowaniu zawodowych kompetencji. Dołącz do nas. Ucz się i lecz świadomie.
Welcome back, everyone. Now we will start a quiz. This will be a 30 multiple choice question quiz. Again, your phones will show you buttons and colors matching the answers on your screen. To participate, you have to take your phone and enter the website kahoot.it, then click play. A window will appear when you can insert the code, which will be shared with you in this transmission in a minute. After you insert the code, the game will ask you to write your nickname, which will be your representation throughout this game. You have to answer not only correctly, but also quickly, because both measures are equally important to win. After each question, the current score table will be displayed. And don't worry if you do not end up in the top right away, the ranking usually changes multiple times throughout the game. The winners of the first 3 places will receive a prize. We ask them to contact us by email, which is on the chat on the YouTube transmission, and send a screenshot that confirms that you are the winner. I hope the rules are clear. Now let's begin. But before we begin, I would like to thank again our patrons and our sponsors. Our patrons are the Minister of Health Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, the Rector of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, and the Student Government Association of the Medical University of Silesia. The most gratitude is for our sponsors of the quiz prizes, which is Compendium Medicine, Corpus Mind, Eldan, Medantlers, Medycyna Praktyczna, PZWL, and Więcej niż Lek. So now let's begin the quiz. Okay, I think we are ready to begin the quiz. So get ready for the 30 questions and go. Okay, congratulations, 4 out of 5 people have answered the question correctly. And now to the table of the scores. And for the next question. Okay, so 50-50. Now we will move on to the scoreboard. And this is a general medicine quiz, so there is a mix of different topics. Okay, this wasn't the greatest question I can see. So now for the table of the scores and up to the next question about acute intestinal ischemia. Okay, next question. And now a question about some basics for biochemistry. Okay, up for the next question. Okay, this was a question where most of you knew the answer, so now we can go on to the next question and the table of the scores. Here you have to think about non-natural death. So no natural death is a death by fall with complications, because this isn't something that you would predict. Now for the next question. Which function is not associated with the dorsolateral prefrontal cortex? Okay, Green Ostrich has a series of 3 correct answers in a row. Congratulations. Okay, this was an easy question. So again, congratulations to Prędki Oryx, you are on the top of the list. Green Ostrich is on a roll, so looking good. What is the most common bacterial pathogen in school-going children? So keep in mind about the children. Okay, for the next question about milestones in children. Okay, only one person got this correct. And again, about the milestones in children. Okay, everyone had a different idea about this. So keep in mind here we were asking for advanced language development, and using single words wouldn't be advanced. So we are now reaching the middle of the quiz, and we are now in emergency settings. Okay, everyone got this question correct. Congratulations. And now for the table scoreboard and for the halfway question about anatomy of the brain. Okay, only one person got this correct. Congratulations. And now we are looking at the scoreboard. Now for the next question about a 2-year-old patient that gradually develops unilateral photoid nasal discharge. And what is the most likely cause? Okay, no one got this correct. So corpus alienum means the foreign object was in the nasal cavity. So that would be the correct answer. And here's the leaderboard. So we are keeping very steady. Now for the next question about the Glasgow Coma Scale. Okay, again, the answers are spread wildly throughout all of the possibilities. And now we will go into the next question about the anatomical plane that divides the body into cranial and caudal. Okay, so 2 people got this correct. Now for the next question about ultrasounds detecting liver bleeding and which is the reason why it is less suitable. Okay, this was a greater question. 3 out of 4 participants have got this correct. And now moving on to the table board and to the next question about the type of probe in abdominal ultrasounds. Nearly everyone got this correct. Now moving on to the 21st question, so only 9 more to go. So this was a very good question. 4 out of 5 have got this correct. Now looking at the scoreboard, Śnieżny Delfin is going up. And for the next question about computed tomography scans. Okay, everyone got this correct. Congratulations. And Green Ostrich is back in the game. Nearly everyone got this correct. And now for the table scoreboard. What initiates electrical conduction in the heart? Okay, this was a quite good question. Now for the next question, we are now reaching the end of the quiz. 5 more questions to go. CF is cystic fibrosis. Okay, only 1 person got this correct. So I hope that this will also be valuable for you to learn. Now, Green Ostrich has a series of 6 best answers, so congratulations. And now moving on to the next question. Again, we have quite a division in the correct answers. And now I'm looking at the scoreboard. This is a very big distribution, so everyone had a different idea. Now we will continue on to the next question. Here is the updated scoreboard. So good luck to Rozsądny Finch, Prędki Oryx, and Green Ostrich. You are currently at the top, but there are still 3 more questions to go, so you can try your luck in getting to the third place. This was a very good question. Everybody got the answer correct. Updated scoreboard. And moving on to the final 2 questions. And now we have the final question before our break. And we have reached the end of this long quiz. So congratulations to the winners Rozsądny Finch, Prędki Oryx, and Green Ostrich. Again, please take a screenshot showing your nickname and send it to the email that is in the chat on the YouTube transmission. Now we will begin a 40-minute break until 1 p.m. 15 minutes past 1 p.m. And again, I would like to extend a big thank you to our patrons, the Minister of Health, Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, Director of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, the Student Government Association of the Medical University of Silesia. I would also like to express our gratitude for the sponsors of the quiz prizes, Compendium Medicine, Corpus Mind, Eldan, MedAntlers, Medycyna Praktyczna, PZWL, and więcej niż lek. See you in 40 minutes again for the next speaker, which is Pasquale Striano from the Institute in Genua. Good morning, good afternoon, everyone. After the break, welcome to the International Medical Erasmus Conference 2024. My name is Julia Ślążek, and I am currently the host for today's event. For the remaining parts, we will hear some more excellent speakers, and we will have one more quiz at the end. Before we begin with the lecturer, Professor Matej Drobnič, I would like to extend a thank you to our patrons, the Minister of Health Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, the Rector of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, and the Student Government Association of the Medical University of Silesia. I would also like to express our gratitude for the sponsors, which are Compendium Medicine, Corpus Mind, Eldan, Medamplers, Medycyna Praktyczna, PZWL, and Więcej niż Lek. And now I will introduce our next speaker, who you can already see on the camera. This is Professor Matej Drobnič, who is the head of Chair of Orthopedics at the Faculty of Medicine of the University of Ljubljana in Slovenia, and he is also the president of the Slovenian Society for Cell and Tissue Engineering. Professor Drobnič will be discussing an orthopedist view of participation in sport. Welcome, Professor. You can share your screen by using the green button on the bottom of the Zoom call.
Thank you very much for the invitation, and I'm glad to give the presentation here. Yeah, let's start. Okay, just to check whether my presentation is rolling.
Yes, we can see the presentation and we can hear you as well.
Okay, good. So I'm going to try to share my view or orthopedics view on the participation in sport. So as I was introduced, I'm working a lot with sports injuries, with arthroscopies, lower limb reconstructions, especially very much focused in the cartilage repair. So when you deal with these elite athletes and some of these guys who are there in the picture, I also treated, there is always a kind of a balance, you know. On one hand, it's your duty to help them to get back to field as soon as possible, and on the other side, it's you need to protect their health and not to over exaggerate. So you are kind of in your internal disagreement when is the right thing to do, when to stop them or when to push them. So this is what drives me to give the title of presentation as I'm giving today. Here are my disclosures. They are not related to this lecture in particular. So if we consider sport participation, there is always, I would say, a general opinion that sport is good, you know, and it's been proven many times. It is good for general population, for different aspects of health conditions, for social benefits. So it's been shown that dose response induces positive changes in musculoskeletal, cardiovascular, respiratory, endocrine, immune, metabolic, and all the other segments of our body. It is also very positive to participate in sport for the risk populations, such as those with anxiety, depression, and chronic pain. It's also been shown that if you participate in sports as a young kid, that would drive you in a good health, better teamwork, you would have better job opportunities also later on in life, as you see here on this slide on the left side. But there is always a but, you know. The sport participation, on the other hand, induces some side effects. So if we look at this chart on the right side below, you would see that there are some benefits and also some, how should I call them? non-benefits or side effects when doing sports. Like you can, on one hand, induce muscular hypertrophy, but if you would over-exaggerate, you would go into the area where you would start inducing injuries. So we need to be somewhere in this thin line to balance, not to go into the injury area of our tissues. Well, the first question that I'm always curious about is what is the definition of an athlete? Because if you would consider the definitions, they are really vague. So the most general, an athlete is a person who is trained or skilled in exercise, sports, or games requiring physical strength, agility, or stamina. And there is always a kind of a dispute. Are you an athlete? Are you a sportsman? Are you an exerciser? Because these differences are really minor. So basically, the best definition for an athlete is this one from the American Heart Association that says that you need to compete against others. And this is a central component of being an athlete. So if you just exercise, you're supposedly not an athlete, you're an exercises. But if you compete against others, then you can consider yourself being an athlete. On the other hand, sports men or sports women, that would cover all of both populations, so athletes and exercisers. But you know, there was a Nike commercial, the Nike CEO or founders. He would also say, if you have a body, you're an athlete, because you know, if you're an athlete, then you should wear Nike, and this is how the things are going. So anyway, the athlete is the one that competes with the others in sports. The next step we need to define is what is a sport injury. This is a bit more defined, what is a correct term. So the sports injury refers to the kind of injury that most commonly occurs during sports or exercise, but they are not limited to the athletes. So basically, you don't need to be an athlete to get a sports injury. You can be just a recreational subject that gets, for instance, an ankle sprain. So if we delineate the sports injuries, there are two big groups. One are the acute traumatic event. So with one injury, you cause a significant bone breakage. Or there are the others, they're more chronic, the overuse injuries. So with many bites, you can still break the bone. This is the figure first presented by Scott Dye, our orthopedic colleague, about 20 years ago. So he would draw a line, which we call an envelope of function. So if you go beyond this line, then you're in the area of structural damage. So your tissues will fail. If you function below this line, you would be pretty safe with regard to your tissues. So if you consider this graph in colors, you can, with certain amount of training, so with supraphysiological loading, you can increase the zone of structural failure a bit, but not to the very top. So this envelope of function is somehow defined by training and by the personal characteristics of an individual. So it's not that everybody is resistant to the sport loads as the others. And the special problem with doing the sports is the growing skeleton. So in the growing skeleton, we have the growth plates or the physes, which are epiphyses where the muscles are attached, and apophyses where the muscles are attached, and epiphyses which are in the articular areas. The second growth spurt, so in the adolescent, we have highly competing individuals in sports, we have a fast growth, and that would all cause certain disturbances on our growth plates. So if these disturbances are severe, they can even close down. So one part will grow and the other one will not. Well, it's more likely that this is not happening so commonly, but more likely we would get the overuse injuries of the growth plates of the apophysis usually, and they are very common, like Osgood-Schlatter disease, Sever disease, osteochondritis dissecans. They are omnipresent in the adolescent sporting population. And there is also additional stress on the growth plates. This phenomenon in football players quite a lot. And, you know, there is a general opinion that the football players, they have bow legs. So first, this needs to be proven whether they really have more bowing than the general population. And that was proven before that we did our study. So we just confirmed it. So we also showed in the group of former professional football players that they have more bowing of the legs than the general population. And what else were we able to show? So we compared the adolescent football and ice hockey players. And we showed that they both move over the same trajectory. So both populations have more bowing of the knees or of the legs than the general population, but there were no differences between the two. So there is a link between sport participation and being more varus knees. It's been also shown, for instance, that jumping sports like basketball, they would induce similar stress on the growth plates of the hip. That's why we can later have the deformities of the hips. There's been also shown, for instance, that participation in supinating sports would cause more high-arched feet than the flat feet. So there is some non-traumatic effect on the growing skeleton by sport participation. The most important contribution that I would say from our research team was that we really showed the growth plates by the diffusion imaging. This shows the movement of water molecules, and we measured the diffusion in the growth plates around the knee of the adolescent football players. And we showed that during the calm period of holidays, the diffusion coefficient in the medial tibial growth plate was higher than during the playing period. So less water movement would mean stiffer tissues. So it means that in medial growth plate of the tibia, there is some overload going on, and that would then later cause the bowing of the proximal tibia toward the skeletal maturity. How about the incidence of sports injuries? So the general statistic shows that the average injury rate in sports is 2.64 per 1,000 hours of exposure. So hours of exposures means that you can have one athlete participating 1,000 hours, or you can have 1,000 athletes participating 1 hour. Of course, it's not completely the same, but usually this is how the incidence is reported. So if you look, there is different sports would induce different type of injuries. So basketball would induce totally different injuries than cycling, but somehow similar than soccer and so forth. So you have to be aware that every sport discipline has special sports injuries that go along with it. Then the next question is, does it more happen during the training or during the competition? There are about 10 times higher risk for sports injuries during the competition than during the training. But since we train much more than compete, that's why the numbers of the injuries are more commonly coming into the training period, but it's still, if you calculate the risk of exposure, it's still much less. When we look at the different type of the bodies, so the knees, lower leg and lower back are the most commonly involved if you look generally. So we also studied a bit our population in Ljubljana and Maton in Slovenia, and we compare this to other studies. So it's really, how should I say, shocking when you see how much intense the running can be. So we would all think that running is recreational running is some sport that you cannot get injured, but that's really not true. There have been, in our study, 15% of participants at the Ljubljana Marathon were not there. So during the whole time period, there is 15% of the recreational runners that are injured for more than 4 weeks that cannot compete. And 1/2 of them had a serious injury, meaning being out of sport more than 1 month, at least once in their career. So if you know, in Slovenia, we estimate we have about 40,000 runners. That's about 2% of the population. So if you bring these numbers of the incidence of sports injuries to this population, you see what a mass of patients we are dealing with. On the other hand, if you look at the football, you know, Slovenian Football Association has about 40,000 registered players, and then we have about the same number of recreational players. So football has one of the highest incidence of injuries, so about 8 injuries per 1,000 hours exposure. So if you just calculate the numbers of the injured athletes just from running and football, it's just, the numbers are unimaginable. So it's not that sports is so healthy for the musculoskeletal system as we would think of. So what are the acute consequences of a sports injury? So if there is an injury, we try to push the player back to play as soon as possible, either by conservative or operative means. But nevertheless, they stay out. They are for different injuries. They would stay out of the field for different time periods. And that would, of course, mean loss of their time and the resources. So on this chart on the lower left, you would see that ACL or Achilles tendon, they are the worst. They would ground down the player for nearly 3/4 of a year to get them back to play. So when you calculate the exposure in sports and time loss for an injury, you see that the ACL, Achilles, they are very high. So they would really mean a lot of damage to a sport participant if they occur. So we would like to get to minimize them as much as possible. How about the long-term consequences of sport injuries? So as I mentioned, there is always an option of physical injuries and growth disturbances on the adolescent athletes. But even in the adult athletes, we have the residual problems after injuries, which is knee osteoarthritis, low back pain, ankle ligament instability, or upper limb symptoms in the overhead athletes. And there is also an option for psychosocial disturbances. So if there is one very eager player being promised a good contract and then they get injured and they would be out of play for half a year, those contracts will perish and they will be lost in space. So it's not just the musculoskeletal, it's also the psychological system that suffers from sports injuries. And if you look at the tables down below, so this 11% when you see permanent. So after a sport injury, 1/10 of a sport participant never returns to full playing. So this is quite a high number. in comparing to work injuries, this is much less. The workers, they would usually go back after they have healed. But in sports, they would heal longer, and some of them will never manage to get to the same level. So the end point of all these sports injuries is the suffering of the cartilage. It's very strange, but if you have a ligament injury, if you have a bone breakage, everything can heal, but that would accumulate damage to the articular cartilage. So the most problematic parts on the long run are this with the broken line. This is the degenerative wear and tear mechanism. So cartilage is cracking, fissuring. Also, the other tissues are going along. So the more damage you would induce in your younghood to a joint, the more osteoarthritis you will have, and earlier you will have it. This is quite well correlated. So we studied a population of former football players playing in the first Slovenian division, and then retired at least 5 years when they were enrolled in the study, and we compare it to the ordinary population, matched by gender and age. So what we saw, a very, very nice conclusion from this study, that the players or the knees of the players, because we were studying the knees, each knee separately. So the knees that were not injured had a similar ratio of osteoarthritis as the general population. On the other hand, the knees that were injured or even operated or injured more times, they would have a higher, very high risk for developing osteoarthritis. So this study showed, as similar other studies showed as well, that the sport participation is not harmful, but getting injured during the sport participation, it is. So for the end, should we do sports or should we not do sport? It is a pertinent question, but I would say from most of the data out there, we can say that the benefits of participation in exercise and sport do make positive outcome on the biological, psychological, and social perspective. So it's more positive than negative impact of them. So we can say that moderate amounts of exercise and sports provide the most optimal balance. However, the intensity is specific to the individual's exercise capacity. So there are not persons alike that we would just say, no, you can run 10 kilometers and from then on you are in danger. But there is an international recommendation that if you do 150 minutes of aerobic exercises and 2 resistance exercises sessions each week, this would generally be applicable. So it means that it would give more benefit than the damage to your musculoskeletal system. Of course, if you consider these numbers, this is way low than any elite athlete will train. And we can also say that there seems no association between sports participation and exercising and the onset of idiopathic osteoarthritis. So not just football by itself will cause knee or hip OA, but on the other hand, if you get injured during the sport participation, the risk for osteoarthritis is increasing significantly. So we have to be aware on the injury prevention programs in sport that are getting bigger, growing, and this is very important message of this talk. So please do exercise, but don't get injured. Thank you.
Thank you, Professor Drobnič, for this interesting presentation. I think especially in the conditions of the summer holidays nearing us very, very rapidly and the student exam sessions, I think we should take this into consideration that despite the studying and the load of studying that we have to do, we still have to remember that some physical activity is recommended for us in order to keep healthy. Thank you very much for joining us today, and I hope to invite you to the next editions as well for our conference.
Thank you. Glad to participate.
Thank you. Now our next speaker will be Professor Pasquale Striano, a board-certified neurologist and pediatric neurologist. He is a full professor of pediatrics at the University of Genoa, Istituto Giannino Gaslini. Now I am trying my Italian. Professor Striano is a member of the board of the Italian League Against Epilepsy, as well as an associate partner of the Euroepinomics Consortium. Professor Striano will be representing decoding early onset epilepsy and targeted disease management, the importance of genetic testing. And thank you very much for joining us today.
Thank you very much, Julia, for your kind presentation and introduction. And thanks so much to my friends and eminent colleague, Professor Justyna Paprocka. I really appreciated this invitation. And I will try to stay in the 20 minutes which have been given. The title of my presentation is Decoding Early Onset Epilepsy and Targeted Disease Management, remarking the importance of genetic testing. This is my disclosure. In the last 45 years, research has redefined the cause of many epilepsies as genetics in their origin. Historically, over than 75% of all epilepsy were described or were considered as idiopathic, but several genetic studies has then gradually revealed an important role for genetic factor in several, if not the most, form of epilepsy. So nowadays we know that apart from the acquired or lesional epilepsy, large majority of epilepsy have a genetic background. Of course, we have the single gene familial de novo epilepsy, but most of the common epilepsy are actually oligogenic or associated with the complex inheritance. This is particularly applicable to the adult epilepsy, adulthood epilepsy, focal and generalized. Even more important is probably the relevance of gene modifiers and susceptibility alleles. But this part of genetics of epilepsy remains so far to be largely explored. In particular, in the last decade, the advent of next-generation sequencing technology has led to an exponential increase in the discovery of novel genetic etiology. So in the middle of the 90s, we had a boom of channelopathy. So most of genetic epilepsy were linked to dysfunction of genes encoding for ion channels. Then we have the transitional era of copy number variants and the genome pool studies. And more recently, in the last decade, the advent of next-generation sequencing demonstrated the spectrum of very broad spectrum of phenotypes associated with genetic epilepsy. So far, over the this is outdated, 900 genes have been associated with some form of genetic epilepsy. What is very interesting is if you span on the synapses the protein which are encoded by the genes so far associated with epilepsy, you can still already starting from the BBB, where it is on which endothelium is expressed the GLUT1, the glucose transporter. These proteins actually are located in the presynaptic and postsynaptic areas. So this means that the physiopathological mechanism of genetic epilepsy are complex and very heterogeneous. Of course, the most important and crucial point is this one, the initial axon segment. Here, the potential action starts, and in fact, we have the potassium channel and the sodium voltage channel, which are very, very important for the origin of the action potentials. It's also important to remark the fact that if we look to the electroclinical syndromes, such as Dravet syndrome, infant-sized pumps, West syndrome, Lenz-Gastaut, these electroclinical syndromes may be underlined and may be associated with genes of different nature. So, of course, most of Dravet syndrome patients, over the 90%, are associated with dysfunction SCN1A, the sodium channel block, the dysfunction of the voltage sodium channel, but other genes can also result in the same phenotype. Vice versa, we can have some gene, such as SCN1A again, which, depending from the location, depending from the type of missense mutation, may result in a different electroclinical syndrome. So, in brief, there is a genetic and allelic and phenotypic heterogeneity for the epilepsy. This is very important when we try to do genotype-phenotype correlation. But genes are important, but chromosome maybe even more. You recognize the facial phenotypes of these patients with a very happy face, so happy puppet face, dysmorphisms, and also typical grapho elements at EEG, such as this squared and sharp wave or slow wave occurring in trains, especially on the central and anterior areas. These patients are affected by Angelman syndrome, which is associated with a chromosomopathy associated with 15q abnormalities. And so what I want to say, there are specific epilepsy conditions associated with chromosomal rearrangement. This is a very updated review for Professor Paprocka, and describing, it's a 40-page paper reporting the clinical picture of these patients. So it's strongly recommended to give a look to this important paper, important review. What makes the investigation of children with early onset seizure challenging? What we have said before, I mean that genetically and phenotypically heterogeneous epilepsy syndrome often present a broad and overlapping phenotype. So when you see a patient with epilepsy, it's not always immediate or intuitive to suspect a specific gene defect. So in addition, diverse etiology are individually rare, and at presentation, most of clinical phenotype present common and non-specific manifestation. Moreover, for the case of genetic epilepsy, still there is a relatively low diagnostic yield with the EEG or brain MRI alone. So it's challenging to make an early diagnosis of genetic epilepsy. For the Pareto law, Pareto was a statistical philosopher, and he showed that 20% of action explain 80% of the effect. And this is applicable also to genetic of epilepsy. I mean that most of the genes, which you see on the left, okay, so 20% of the epilepsy gene explain 80% of the phenotype. So this is the strong rationale for using gene panels, at least in some realities, because most of the patients will actually present a genetic variant in one of very few genes, no more than 20, 30 genes. In this paper, a total of 67 pathogenic genes were identified in a large cohort of 300-400 patients. Which are the reasons to consider genetic testing in pediatric epilepsy? There is, first of all, a clinical utility, because this may change in the treatment or management of epilepsy. I will give you some example later. So initiation of a precision treatment, avoidance of a contraindicated treatment, initiation of palliative care eventually, and also syndromic diagnosis impacted surveillance, but also some changes occur in hospitalization rates or change in morbidity or mortality rates. And definitely you can provide prognostic information to the family, to caregiver, and eventually consider clinical trial eligibility. For the patient and caregivers, there is a recurrence risk estimation in genetic counseling and also crucial for reproductive planning. And also there are, a cascade of testing of family members, psychosocial issues, such as end of the diagnostic odyssey, reduction of the guilty sense, shame from the family, and full access to support organizations. So it's very important to consider genetic testing in a very early stage of the disease, if possible, even presentation. But of course, one may think that in this sense, early genetic approach means that neurologist is put aside, but it's not the case. Indeed, there is a pivotal role of neurologists in the genomic era. First of all, documenting clinical feature and collecting family information, and also ordering, addressing the genetic testing, and also being involved in interpretation of genetic result in the clinical context. So far, the genetic testing available include chromosomal microarray. This is able to identify loss and gain of DNA, so chromosomal rearrangement, but it cannot identify balanced rearrangement or ring chromosome. So if you suspect a ring 20 or a ring 14 chromosome abnormality, you should still consider the whole but still valid karyotype. So having in mind what we are looking for is crucial to pick up, to select the best genetic testing. The Sanger sequencing, single gene sequencing, is quite outdated and nowadays used only for segregation analysis and family testing. And it will be even more updated in the next years. The gold standard so far are gene panels, so target gene panels, which are very interesting because they allow a first screening of genetic condition in a acceptable, reasonable turnaround time, up to 6 weeks. And in the future, nowadays, also in some centers, exome or genome sequencing will be the most used genetic testing here because it permits to identify copy number variants. So choosing the best test is very important to optimize the genetic confirmation of your clinical suspect. Of course, the identification of variants of uncertain significance may be challenging, and that's the reason for which partnership with the geneticist is very important. The costs are less and less relevant because the costs overall of these tools will be lowering and reducing in the next few years. So it is expected that in a few years, genetic testing tools will be more and more cost efficient and provide long-term value. So we should, as a clinician, we should lead a paradigm, a shift in the therapeutic in the diagnostic paradigm, which means not waiting from EEG, MRI, waiting for failure of seizure medication, and then asking genomic testing. Indeed, genomic testing should be requested as soon as you suspect an electroclinical syndromes, together with the support of medical geneticists and other colleagues. So do not wait for drug resistance because you can avoid diagnostic delay, and you can also optimize healthcare costs. Genetic testing, based on the recent evidence-based practice guidelines from multiple professional society, is suggested in a very early stage of the disease as a first-line testing. So do not wait. And the chance for a positive genetic result is particularly higher when there is an early age at seizure onset, in patients with developmental and epileptic encephalopathy, in patients with comorbidity, such as neurodevelopmental concern, and in patients presenting with multiple seizure types, such as myoclonic-atonic, tonic-clonic absences, and tonic-atonic seizures. This is a report from a paper presented on epilepsy, and a paper of a large cohort of patients, almost 2,000 patients, showing that the higher percentage of positive genetic testing is associated with language or motor delay, developmental delay, or abnormal EEG findings with multiple seizure types. So these patients are particularly indicative of genetic etiology, and they should be referred to genetic analysis as soon as possible. All right, and another important point is the fact that in the future there will be potential precision medicine treatment. So far, these examples are very, very rare. That's the case of SCN1A patients, Dravet syndrome patients. So far, when there is a dysfunction of sodium channel, you should avoid sodium channel blockers such as phenytoin or carbamazepine, because you can impair even more the channel dysfunction. But vice versa, in SCN2A, another developmental epileptic encephalopathy, in which we have a gain of function, so an increased diffusion of the sodium to the channel, using a sodium channel blocker can be very important. And again, in patients with progressive myoclonic epilepsy associated with TPP1 deficiency, you can think about enzyme replacement treatment, which is so far, at this moment, at this stage, is the only precision medicine approach for a genetic epilepsy. In the future, in the next future, oligosense antinucleotide for Dravet syndrome will be available. This is an intrathecal administration of the drug, which is able to increase the concentration, the expression of the SCN1A allele, which is not defective. So you can counterbalance the defective allele function, and this will be probably a shift of a paradigm for developmental epileptic encephalopathy. Let's see what happens in the next few years. But another important last thing I want to remark is the fact that a positive genetic testing may change clinical management of the patient. In this paper, JAMA Neurology, even within 3 months from genetic results, you can choose to add a new treatment, to initiate a medication, to refer the patient to a specialist, or stopping a medication. So in other words, the genetic result, the genetic findings does make an impact, and you can take an action. So it's very important to consider an early stage. And also, genetic testing allows the clinician to refer to other specialists. So once that you have a final confirmation of SCN1A or CDKL5 or SPIC1, you can also ask for genetic testing, genetic counseling, cardiological and ophthalmological evaluation, psychiatric assessment. You can ask for the nephrology or pneumology specialist, the behavioral specialist, and so on. So it's very important to have a comprehensive and global approach to these patients. So far, this is a very pragmatic and practical recommendation. If you have a well-defined epilepsy syndrome, for instance, Dravet syndrome or developmental epileptic encephalopathy, gene panel or exome sequencing still should be the first line testing. But if you have a patient with developmental delay or a relatively undefined epilepsy syndrome, or if you are not very confident with your epilepsy expertise, you may consider chromosomal rearrangement, and so you may recommend a RACGH and then karyotype and eventually gene panel and finally genome sequencing. This is a gross therapeutic diagnostic algorithm. In the future, neonatal screening will be very important because it will allow us to identify an early stage genetic or neurometabolic epilepsy, and this will be very, very important again for a therapeutic paradigm shift. So finally, uncovering the genetic cause of an epilepsy, a pediatric epilepsy, is the first step to eventually reach a better diagnosis, a target disease management, and eventually have an impact on patients and their caregiver. And thank you very much for your attention.
Thank you very much, Professor Striano. We are very grateful for your attendance to our conference. I hope that I am saying your surname correctly. And thank you again for your presentation. It was very interesting. And I hope that we will have the opportunity to hear from you in the future as well.
Thank you, Julia. Thank you all for listening. Take care. Bye.
Thank you. And now we are pleased to have Justyna Paprocka, our amazing Erasmus coordinator, who helped organize this conference, for which we thank you very much. She will guide us on how to Erasmus Plus, so how to go for an exchange. And you can share your screen if you have a presentation by the green button on the bottom.
Okay, thank you very much, Julia, for introduction. Can you see my presentation?
Yes, we can both hear you and see the presentation.
Great. So my name is Justyna Paprocka, and I am responsible for Erasmus Plus office at the Medical University of Silesia. And today I would like to share with you some basic information about Erasmus Plus program. As you can see, the topic of my presentation is how to Erasmus Plus, which is quite a large topic. So firstly, I would like to answer the question, what is Erasmus Plus? And the Erasmus program was originally established by the European Union in 1987. It looked to promote closer cooperation between universities and higher education institutions across Europe. This meant setting up an organized and integrated system of cross-border student interchange. And why the name Erasmus? The choice of the name Erasmus refers obviously to Erasmus of Rotterdam, who's scholar and inspiring lecturer during the Renaissance period. He extensively traveled in Europe to teach and study at a number of universities. But at the same time, the word Erasmus also served perfectly as the acronym for the European Community Action Scheme for Mobility of University. So that is why Erasmus. Erasmus has evolved from its initial focus on higher education to a program that now supports education, training, youth and sport in Europe. It has an estimated budget of 26 billion euros. And for the period 2021-2027, program places a strong focus on social inclusion. European Union fights for the people with fewer opportunities due to economic reason or any kind of disability. the green and digital transitions. European Union, due to climate change, promotes green and ecological solutions, and promoting young people's participation in democratic life. Erasmus Plus offers mobility and cooperation opportunities in many different fields: higher education, vocational education and training, school education, including early childhood education and care, adult education, youth, and sport. Obviously, this conference is dedicated to students, doctoral students, researchers, academic teachers, so people related to higher education field. That is why now I would like to dive into opportunities of Erasmus Plus program for higher education. So here we have 4 major actions. Key action 1, learning and mobility of individuals, the most popular one, and I will discuss it in more detail in a moment. Key action 2, cooperation among organizations and institutions. It's about educational projects carried about at least by 3 European institutions from different countries. Key action 3, support to policy development and cooperation. And this action contributes to the development of new policies which can trigger modernization and reforms at the European Union in the field of education. And Jean Monnet actions. And these actions promote excellence in teaching and research in EU studies worldwide. So let's dive into key action 1, learning mobility of individuals, the most popular one. This action supports physical and blended mobility of higher education students in any study field and cycle, so short cycle, bachelor, master, and doctoral levels. Students can study abroad, carry out a traineeship, combine a study period with a traineeship. And student mobility is divided into 2, student mobility for studies and student mobility for traineeship. Regarding student mobility for studies, unfortunately, it is not possible to study at any university. Students have to choose the university from a partner universities list. It means that your university has signed interinstitutional agreement with a foreign institution, and this agreement is required. And the mobility for studies lasts of 2 a minimum and 12 a maximum months. Student mobility for traineeship, I think, which is the most popular. You can carry out a traineeship in an enterprise, a hospital, a research institute, a laboratory, an organization, or any other relevant workplace abroad. And long-term mobility lasts a minimum of 2, a maximum of 12 months. And there is also a possibility of short-term mobility, which has to be combined physical mobility, 5 to 30 days, and a compulsory virtual component. It is compulsory for first, second cycle and master degree, and optional for doctoral candidates. Don't be afraid of this virtual component. It might be an online meeting with discussion of rules of course institution before the mobility, or discussion and summary of the traineeship after the mobility, because the virtual component can take place before, during, or after the mobility. And what is interesting, and what I really like to point out, student mobility for traineeship is available also for a recent graduate. So up to 12 months after graduation, students can participate in the mobility for traineeship. At our university, this possibility is very, very popular because our students has to complete an obligatory postgraduate internship after studies. And sometimes they decide to complete, for example, 2 months abroad. So surgery in Germany. And it is a really valuable experience because they have the possibility to learn about foreign healthcare system. Key Action 1 also supports higher education teaching and administrative staff to take part in professional development activities abroad. And these activities may consist of teaching, or training, such as job shadowing, observation periods, and training courses. Finally, this action supports blended intensive programs, allowing for groups of higher education institutions to jointly develop blended mobility curricula and activities for students, as well as academic and administrative staff. Yeah, documents. So before the mobility, the participant has to sign a learning agreement. Learning agreement sets out the program of the studies or traineeship to be followed abroad, and it must be approved by the student, by the sending, and by the receiving institution. While it is quite simple to arrange learning agreement for traineeship, it is really demanding for studies. But here, students can ask the faculty coordinator for help, and the faculty coordinator will guide you, will help to choose courses abroad to be then able to complete the year at your home institution. The information on this slide, I think, is the most interesting for everyone who is willing to participate in the Erasmus Plus program. So here you can see the monthly scholarship. European Union decides each year about amount of grants. And as you can see, European Union divides countries according to the cost of living. And for the first and second group, the monthly scholarship is the same. For the third group, is a little bit lower. And it is also lower, always lower for studies. So maybe that is why of the reason why students really would like to participate in student mobility for traineeship. And finally, I would like to answer the question, how to Erasmus Plus. So first of all, we highly recommend to check your university Erasmus Plus website and to read and learn about recruitment rules, recruitment deadline, what documents you have to submit, for what extra points you can have. These are very important questions. Analyze the list of partner universities. Go to the website of the partner university you are interested in and check the available courses, the language in which the courses are held, because some universities do not provide classes in English. So it might be difficult to study and pass exams, for example, in French or in German. Also, the organization of academic year is very important, especially when you want to study in spring semester. Sometimes spring semester starts later, sometimes earlier, and it might be difficult to combine the beginning of spring semester with the examination session after winter semester. Also check the possibilities of getting to the chosen university. So if it is possible to get there by plane, by bus, by train, and accommodation offer in the region. And finally, talk to people who have already completed their mobility. They are willing to share their experience, which can be very, very helpful. And in many places, there is also a non-profit international student organization, ESN, which is also very, very supportive. So just go for it, because thanks to Erasmus Plus program, you will meet people from all over the world. And here I have to say that one of our students who was studying in Italy 2 years ago, she met her current husband. She moved to Italy, so Erasmus Plus completely changed her life. Improve your language skills, learn about different culture, experience a different teaching system, become bolder and more confident. And Erasmus Plus mobility is an amazing adventure. Yeah, here you can see the picture of our Erasmus Plus students, incoming students. We were together in a coal mine, which was a great experience. So thank you very much for your attention, and I hope that maybe in the future you will participate in Erasmus Plus program.
Thank you for this presentation. I think the highlight of the presentation is the life-changing experience of meeting a husband in Italy. So I hope that the viewers of our conference will be much excited to join Erasmus and include their experience in the Mobility Plus program. Thank you.
Thank you.
And now we will welcome Professor Thomas Berger, the chair of the Scientific Committee of the European Academy of Neurology and the past president of the Austrian Society of Neurology. Professor Berger will discuss the autoimmune central nervous system demyelination, multiple sclerosis, neuromyelitis, optica spectrum disorder, and myelin oligodendrocyte glycoprotein antibody-associated disease. Welcome, Professor Berger, and thank you for joining us today at the International Medical Erasmus Conference.
Yeah, hello. Hi, Julia. Thank you for the very nice introduction, and I'm also very glad and grateful to Professor Paprocka for inviting me. And I will now try to share my desktop, which seems
it's
not
on the green button on the bottom of the...
Yeah, but it does not work. Oops. It's getting difficult. Why does it not work right now?
You can also try on the keyboard Alt S. Maybe that will...
Interesting, because usually it worked perfectly. Interesting enough.
That is the nature of things.
Yeah, because it says I need to go into my system to allow the... Right. Oops. Okay, I will try it this way. So let's see whether it works. Very interesting that it does not work. I'm really sorry about that.
Maybe you can share the presentation on email, and then we will share the screen for you.
Okay, whom do I send it?
I will send you on the chat. I will send you the email.
Okay, I'm sorry for that, because I just had another meeting an hour ago without any problem.
Okay, so on the chat, there will be the email to share your presentation, and you can send it there, and then we will share the screen for you. And I think that might be the easiest option.
So I tried in the chat, but in the chat there's nothing to see for me right now. Here it is. Okay. I'll try.
Okay, maybe we will... Okay, maybe we'll have a small technical break for an advert on the YouTube transmission, and meanwhile we can try figuring out what is wrong with the screen sharing.
Okay, so if I'm now...
Na myśl o studiowaniu medycyny lub wykonywaniu zawodu lekarza często rodzą się w nas wątpliwości. Z czego i jak się uczyć? Jak zdobyć praktyczną wiedzę? Gdzie szukać wsparcia innych? Wyobraź sobie miejsce, które dostosuje się do Twoich aktualnych potrzeb edukacyjnych. Miejsce, w którym możesz zadać każde pytanie i uzyskać odpowiedź. Miejsce pełne atrakcyjnych i praktycznych materiałów edukacyjnych, które same się aktualizują. Tym miejscem jest portal Więcej niż lek. Znajdziesz na nim kursy e-learningowe, stworzone tak, aby umożliwić Ci efektywną naukę w atmosferze wzajemnego wsparcia, rozwoju, zadawania pytań i uzyskiwania odpowiedzi. Koniec z wertowaniem podręczników przepełnionych litym tekstem czy korzystaniem z nieaktualnych materiałów. Już dziś dołącz do wirtualnych pokojów nauki, dzięki którym wspólnie z innymi będziesz efektywnie uczyć się z materiałów edukacyjnych dostosowanych do Twojego etapu rozwoju zawodowego, podczas studiów, przygotowania do egzaminów końcowych czy w pracy lekarza. Więcej niż lek to medyczny portal edukacyjny, wspierający efektywną naukę medyków oraz pomagający im w świadomym budowaniu zawodowych kompetencji. Dołącz do nas. Ucz się i lecz świadomie.
Does it work?
Begin. Yes, we have to restart the YouTube transmission so that everyone can see. So again, welcome, Professor Berger, and we can't wait for your presentation.
Yeah, thank you once again, and I'm sorry for the delay. Nevertheless, I would like to join you with a short journey about how developments in research, and specifically on autoimmune CNS demyelination, have changed the routine clinical landscape, and this will be shown here. So autoimmune disorders of the central and peripheral nervous system are numerous. So there are many autoimmune disorders. Up front is, of course, the group of multiple sclerosis, but others, as also indicated in my title, neuromyelitis optica spectrum disorders and MOC-associated disorders. So I will touch those three because they are mainly truly demyelinating disorders based on autoimmune inflammation. So having said that, I think we start with the old notion and also recognition that MS is a kind of large family of disorders, including some variants, and these variants are defined by this well-known godfathers of MS research, more or less 100 years or even more ago, starting with Jean-Martin Charcot. So the idea was that MS is a group of inflammatory demyelinating central nervous system disorders, and also incorporates some variants, including also ADEM, which is the acute demyelinating encephalomyelitis. Now, what about MS itself? Just to bring us all on the same page, MS is the most common neurological disorders of young adults with the potential risk of a further disability. So worldwide, there are approximately 3 million people affected by multiple sclerosis, and this depends on the prevalence, which has a certain distribution, which is along with the geographical distribution. It's not really entirely clear why there is this north-south distribution with a prevalence or higher prevalence of MS in northern countries like in Europe or in the US, and with lesser prevalence the more you come to the equator or even more south. Nevertheless, the thoughts with this regard has to do probably with genetic susceptibility and or environmental factors. The other point, which is an interesting recognition in MS, is that MS gets more and more the women's disease in neurology, apart from, of course, those disorders which are exclusively happening just during pregnancy, but such as migraine or idiopathic intracranial hypertension, which are very strongly dominated by female patients. This also accounts for multiple sclerosis. And when I was during my studies, the gender ratio between females and male patient was 2:1, and we are now up to 4:1, and this is still increasing. So this is an interesting recognition of MS. MS itself, and this neuropathological image depicts the whole problem in multiple sclerosis, because the pathological hallmarks and characteristics of MS are, on the one hand, inflammation, which is here shown as macrophages. Then there is demyelination, which is seen here. Axon denotes, or X denotes the axon. And what you can see here is a thin rim, which is the myelin sheet, the protective sheet around the axon. And this is here disrupted, which means here's demyelination. And demyelination, of course, is the fundament for the vulnerability of the axon, and also the damage or even destruction of the axon. If this takes place, there are two options. The one is that there is an astroglial scarring, which is the name giving for multiple sclerosis, because, as you know, that means multiple scars in the brain and spinal cord. And but the other way is also something which also has changed over the past 25, 30 years, that there is a good option of regeneration, also including our central nervous system, which means in the case of MS that there is the possibility of regeneration in terms of remyelination. And this is seen here with this thin dark rim, and this is a remyelinated axon. So endogenous repair might happen, but of course very strongly driven by the extent and the duration and the sustained autoimmune inflammation. However, with regard to the inflammation, and you can see here also an electron microscopy graph, where you can see that the T cell is entering the blood-brain barrier, and therefore also the central nervous system. The key question is, what are the driving forces for these T cells, and what brings them in? What is the attractant and the pathfinding mechanism of these T cells? And to make a long story short, this is experimental work which I was dedicated quite some while ago in the lab of Professor Lassmann from the Brain Research Institute in Vienna at the Medical University. And what we have been looking, and this is known since the 50s of the last century, that if you inject autoreactive T cells to a recipient animal, in this case it's Lewis rats, you can induce inflammation. So this was thought since this time that this is a good model for multiple sclerosis. However, it was not clear what are the driving antigens, the main antigens, which are the target of those encaphalotogenic T cells. Now, again, to make a long story short, it could be any protein in the brain which is the target for the initial inflammation. And this is very important because it's not only a target on the myelin sheath, which then would lead to demyelination. It could be any, even those who are not related to the myelin sheath, like S100, which is a structural protein of astrocytes, or even completely agnostic antigens in terms of MS, like heat shock proteins. So the initial starting point is a local inflammation. Nevertheless, we also have to admit that MS is not an inflammatory disease, an encephalitis alone. It is an inflammatory demyelinating disorder. And these animal models, specifically in this Lewis rats, did not show any demyelination. So the question was, how good is this truly a experimental model for the human condition of multiple sclerosis? And then we injected in a kind of co-transfer antibodies against myelin proteins. And suddenly, you can see this here on this histographic image, if you inject those antibodies, you get this patchy demyelination, which means that obviously the interplay between T cells and B cells / antibodies is highly important for the human disease of multiple sclerosis, indicating that there's inflammation and demyelination. And it also indicated that there is obviously an important role for B cells. And this was shown in a very seminal work by a colleague. Unfortunately, she died already, but she showed that in an active lesion of a biopsy from an MS patient, there are mainly B cells and plasma cells. And then they started a journey. And this journey was driven by neuropathologists, again, Professor Lassmann from Vienna, but also Professor Lucinetti from the Mayo Clinic and Professor Brück from Göttingen in Germany. And they were looking at various tissue samples, be it autopsy, be it biopsy of MS patients. And they found that the demyelination, and this is shown here, the demyelination follows exactly 4 patterns. And this is regardless whether a patient probably had a biopsy one day and years or decades later an autopsy, it was always the same pattern. So based on a common inflammation, as shown before, there are different patterns of the way how demyelination can occur. And one very interesting pattern is the pattern 2, because this one is antibody-driven. And this antibody-driven subtype of demyelination, if they, when they went back to the clinical reports of the patient, it suddenly happened that they were more or less exclusively cases of neuromyelitis optica. And this defined that obviously there seems to be a humoral mechanism, which means B cells and antibodies playing an important role in neuromyelitis optica disorders, which was thought, as you probably recall my initiation slide, that a subvariant of MS. Now, it then didn't took too much time. If there was an antibody playing a role, then it was necessary to identify those antibodies. And indeed, the Mayo Clinic, Van der Lennen, specifically identified that this IgG antibody in NMO was an antibody directed against a water channel, the so-called aquaporin 4. And with that, suddenly there was an antibody there indicating that this separates the entity of neuromyelitis optica versus other inflammatory demyelinating disorders, namely specifically multiple sclerosis. One of the most important things in antibody research is also to establish 2 important demands and or to meet 2 important demands. The one is that those antibodies truly have to be pathogenetically active. So they are not only a bystander effect, they need to be truly pathogenic. And the other point is, of course, that these antibody testing systems also have to be validated. And we contributed very much to this, especially together with my colleague, formerly in Innsbruck, Markus Reindl. So we established the gold standard of antibody measurements in neuromyelitis optica, and the gold standard is a cell-based assay. However, there was still one question: why does the clinical symptoms of neuromyelitis optica, which means optic neuritis and mainly myelitis, but also others like in the area postrema, which means brainstem, or other locations, it's very clear because these are the locations where the aquaporin 4 antigen is expressed. And therefore, if you have an antibody directed, you would also have clinical symptoms, which are, of course, represented by those areas. Now, the last missing link in this loop of antibody research was to prove that those antibodies are truly pathogenic, which means that from patients, you need to take samples. In this case, it was a sample series of patients who had plasma exchange, and these plasma eluates were concentrated, the antibodies were defined, and then together with the group of Hans Lassmann, these concentrations of the plasma eluates were injected to animals, and suddenly those animals got neuromyelitis optica-like disorder, which indicates clearly that those antibodies are truly pathogenetic antibodies. So what happened as a next step is that those antibodies were integrated in the classification for diagnosis of neuromyelitis optica spectrum disorders and clearly define if somebody has a suspect a CNS demyelinating disorder and aquaporin 4 antibodies, you are in the group of neuromyelitis optica spectrum disorders. And the other point is, of course, and I would like to show you one index case with a classical transverse myelitis as seen in the neuromyelitis optica spectrum disorders, plus also bilateral optic neuritis. However, this patient had no antibodies against aquaporin 4. So she had the phenotype of NMOSD, but not aquaporin 4 antibodies. However, it turned out that this patient had MOG antibodies. And this led to a very important also work indicating that patients who are aquaporin 4 negative, they harbor MOG antibodies. Now, if you are probably familiar with the various antigens, then MOG is an antigen which is on the myelin surface, on the myelin sheath and oligodendrocytes. So it's not an astrocytic, it's an myelin antigen. So this truly leads to demyelination, and it was clear then from neuropathology that there are two pathogenetic pathways in the NMO spectrum disorders. The one is the so-called astrocytopathic disease with antibodies against aquaporin 4, the astrocytic target, and the second one is the MOG associated demyelinating disorder, indicating that this is the second way how neuromyelitis optica disorders can emerge. Now, the interesting part is that then suddenly there was a specific interest to dissect, because it was clear that NMO spectrum disorders are now a clear, distinct entity apart from MS, that this now defined the NMO spectrum disorders, but the revival or the identification of the MOG antibodies also indicated that there might be a kind of spectrum disorders of MOG-associated diseases. And indeed, it turned out that there are specifically in pediatric cases of this ADEM, which is the acute demyelinating encephalomyelitis, that a majority of those pediatric patients have MOG antibodies. And this was shown in a series of publications which we done with neuropediatric colleagues. And this also identified that this is a very important differential diagnostic measure for our new pediatric colleagues. However, there are not only pediatric cases, there are also adult cases. And one example I would like to show here, this was a patient who occurred with headaches and fever, and because he had a tuberculosis some years ago, 3 years ago, it was suspected that he has a tuberculosis meningitis, and he got the appropriate treatment. However, a couple of months later, he developed an encephalopathy and aphasia, and then it was clear it couldn't be anymore a tuberculosis meningitis. And in the CSF, there was a pleocytosis indicating inflammation, and the PCR for the Mycobacterium was negative, so definitely no case of tuberculosis. However, the MRI was very strange, showing this ring-enhancing lesions, inflammatory lesions, and because nobody knew what we should do with this case, the patient had a biopsy. And this is the biopsy channel, And this is the biopsy specimen, and you can see very easily that there are two different colors. The blue one indicates myelin staining, and the red one is the demyelination. So it was obviously that there is obviously acute central nervous demyelination. And indeed, it turned out that it's again antibody-driven, and it's not wondering that this patient also had MOC antibodies. So this is a spectrum also of disorders of the central nervous system, which are quite different from neuropediatric monophasic disorders like ADEM or other, even in adults, disorders which are driven by clinical phenotypes which are at least strange and turned out to be MOC positive. Which means that at the end of the day, the dissection of this former nosographic view that MS plus variants is now on a way to be dissected into different disease entities. It's clear that the NMO spectrum disorders are completely separated from MS cases. Also the same for the MOC-associated disorders. Plus there are already some overlaps also indicated, for example, for autoimmune encephalitis. So with our better understanding of the pathogenesis, but also with the tools for identification of separate CNS demyelinating disorders, we are also able now, and I think this was very nicely shown over the past 20 years, to separate out of this group of MS patients those who do not have MS, but a different disorder. And that this is not only an academic interest, as I initially said at the beginning, is that it found its way into clinical routine practice, because it's highly important if a patient shows up with the first suspected demyelinating CNS disorder. It is very important to differentiate whether this is a first case or situation of a clinically isolated syndrome of MS, or if this is a MOC-associated disorder, probably an ADEM, which is monophasic, or if the patient has a first event of a neuromyelitis optica spectrum disorder. And the reason for this differential diagnosis is that the prognosis of these three entities are completely different. As I said, the MOC-associated disorders are often very monophasic. MS and aquaporin 4 positive NMOSD are relapsing. However, the morbidity and also the mortality is completely different in the NMO spectrum disorders, because you can imagine if somebody has several times bilateral optic neuritis, then the risk of complete blindness is there, and the same accounts for recurrent spinal cord inflammation, because the patient probably might be wheelchair bound. So this is very important with regard to the prognosis and therefore also for treatment, because the NMO spectrum disorders would not only fail with the treatment, which is an MS treatment, they even would deteriorate upon treatments which are approved for MS. And therefore there is, for the acute treatment, it's all the same, but for the prophylactic treatment, for the disease-modifying therapies, there are clear separations, except for one, and this is an anti-CD20 monoclonal antibody therapy, because this is directed against B cells and, of course, also down the road against antibodies. But otherwise, it makes a lot of sense, and it's highly important to separate this in a clinical setting, and also to choose the right decision makings for the patient individually, because this very strongly also defines the further risk in the disease course of the disease. And with that, I'm ready. And once again, I would like to apologize for the delay, and thank you for attending this lecture.
Thank you very much for the lecture, and thank you for agreeing to participate in our conference, because we know that you are a very busy man, and I enjoyed the presentation a lot, and I hope that our viewers also will enjoy it once they watch the transmission. Thank you so much.
Yeah, you're welcome.
And I hope that we might meet again for some other conference editions.
Yes, great. Yep.
Okay. So now we will have the final quiz of the day. Again, remember to go to Kahoot, insert the code, and use the nickname. Let's see who will win this time. Now, what will happen is I will share the screen. You can see the code to the game, so please enter Kahoot. A window will appear where you can insert the code, which will be shared now. After you insert the code, the game will ask you to write your nickname, which will be your representation throughout the game. In this quiz, we have 15 multiple choice questions. Your phones will show you buttons and colors matching the answers on our screen, and you have to answer not only correctly but also quickly. Now, what is important is that the winners of the first 3 places will receive a prize. We ask you to contact us by email, which you will find on the chat on the YouTube live transmission. Sending a screenshot will confirm that you are the winner. So you have to make sure to make a screenshot either at the beginning with your nickname or at the end, so that we know that you are the person, and I hope the rules are clear. Now, before we begin, I would like to again thank you to our patrons, which is the Minister of Health Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, Rector of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, and the Student Government Association of the Medical University of Silesia. I would like to express our gratitude to our sponsors, which is Compendium Medicine, Corpus Mind, Eldan, MedAntlers, Medycyna Praktyczna, PZWL, and więcej niż lek. Now, let's begin the quiz. Okay, so someone listened carefully to the presentation. Now, moving on to the next question, which is not a key objective of Erasmus+. Okay, 2 people have definitely listened in to Ms. Justyna. Now for the table of the scoreboard, Tajemniczy Tygrys and Smiling Shark are doing great. Out of 5 people. That is great. So now we can see that we are having a very close game with Majestatyczny Shop Pracz and Smiling Shark. Now, which sectors can participate in Erasmus Plus projects? Congratulations to all of the 4 people that answered correctly. Which country is not eligible to participate in Erasmus+? Now, for the next question, how long can Erasmus Plus mobility for higher education last? Okay, again, we have 4 participants with the correct answer. Congratulations to Tajemniczy Tygrys with his 6 great correct answers. Now to the next question. We are halfway through the quiz. What has been the new feature in the new program? Congratulations, all of the participants had the correct answer. Now to the 8th question, now in the context of IFMSA-Poland. Now this is split between different answers. So congratulations Majestatyczny Szoppracz and Tajemniczy Tygrys for being at the top of the leaderboard. Congratulations. Now this again, 3 people and 3 others that. Now, which of the following is a common outcome of Scopy exchanges? Okay, Smiling Shark has 10 correct answers in a row. Congratulations. Now, how can a student apply for a Scopy exchange? Okay, here's the leaderboard. So Smiling Shark is very close to reaching the 2nd place as well, which is one of the benefits of participating in the Scopy exchange. Okay, congratulations for the majority of the correct answers. What kind of support do students receive during their Scopy exchange? Okay, congratulations Pogrubienie Seal, 3 in a row of correct answers. Now, final 2 questions. How many national member organizations are there in IFMSA? And which of the following is not a requirement for participating in a Scopy exchange? This is the final question of the quiz. Okay, being a member of the European Union is not a requirement for Scopy exchanges. Everyone is welcome. So here are the results. So congratulations to Majestatyczny Szoppracz, Tajemniczy Tygrys, and Smiling Shark. Please take a screenshot of your screen and send it to our email so that we can contact you regarding the prizes. Okay, And after this amazing quiz session, our last presentation is by Dr. Balazs Feher, who conducts research at the Medical University of Vienna, as well as the Harvard School of Dental Medicine. He is also a contributor to the ITU WHO Focus Group on Artificial Intelligence for Health, as well as a member of the European Association for Osseointegration Junior Committee. In 2018, he was awarded the European Prize for Research in Implant Dentistry, and Dr. Feher will share his knowledge about all of his research in his presentation. Welcome, and thank you for your participation in our conference.
Thank you. Thank you. Can you hear me?
Yes, we can hear you, and we can see the screen as well.
Perfect. Dear colleagues, good afternoon. It's an honor to speak at this year's International Medical Erasmus Conference, and I'd like to thank the organizing committee for this invitation. As it was said, my name is Balazs Feher. I work in Boston and in Vienna, and further relevant to this lecture is my affiliation with the WHO ITU Focus Group on AI for Health, as well as previous speaking fees I've received from companies or industry related to applied AI in dental medicine. Of course, this lecture is not paid, and no third party has seen or influenced its content, so that I am free of any potential conflicts of interest. Now, I think the topic of today is, of course, AI in dentistry, which is a very interesting topic, also related to the surge of interest in AI in the media, as well as in science, but also in clinical practice as it relates to medicine. I think two very important questions, if one wants to immerse themselves in this topic, is why AI and why we're talking about it now. Of course, there's a lot of confusion about these questions, and these are not necessarily questions that are talked about a lot. So even though our time is constrained, we will not be able to get into every single detail of applied artificial intelligence in medical science. I think this still gives us a good framework to think about, even as we talk about the different applications and even beyond this lecture. So our traditional way of doing medical statistics is we obtain data and apply explicit rules to get certain outcomes. Now, of course, these can be, for example, hypotheses tests. These can be associations that are described easily. So a good question to apply classical statistical analysis to would be, for example, is smoking a risk factor for periodontitis, right? This is something that is very easy, a straightforward association between something that is a causal factor or a risk factor for another thing, right? A causes B, or A increases the likelihood of B. This is an association that is straightforward, is simple. We have a lot of hypotheses tests in statistics that we can use for testing associations such as this. Now, what happens if there are a number of things that are more complex than that? For example, what happens if we would just like to ask the question, which of our patients are at the highest risk of developing severe postoperative pain? And if you think about this question, it's phrased in such a way that there might not be just one good answer. There might not be just one factor that led to this patient developing the severe pain. It might be an interplay. It might be a complex network of multiple factors, the interplay of whom has caused the pain in the patient. But of course, we have a big data set because a lot of patients experience certain outcomes, even though we don't know why that might happen. And so if we flip the script, this is where AI comes in. And the basic concept of doing AI in medical research is flipping this chart so that we start with the outcomes, start with the data, and apply a set of specialized algorithms in machine learning to infer implicit rules that are then mapped to the outcome. So we start from the end using large data sets and advanced algorithms to try to find out the underlying rules and associations that we did not know before. So again, just to emphasize the basic premise of the difference between classical statistics and machine learning, in machine learning, there is really no such thing as a hypothesis test that is either a yes or a no answer. We start with the outcomes, we start with the data, and then we apply complex algorithms to map the data to the outcome by way of inferring implicit rules. So if this is the case, then why is it that all of a sudden everyone in the medical field seems to be talking about AI now? And that is because of two reasons. Right now, we are in the era of big data and big compute. So the world's hospitals are generating about 50 petabytes of digital data in 1 year. And to put that in context, just 1 petabyte would be enough to store about 2 billion books at 500 pages each. We could store a decade and a half of Netflix 4K content in just one of these petabytes, of which we're producing 50 annually in digital patient data in the global hospital system. And this big data also needs high level of computational power to know what to do with. This is where something called Moore's law comes into play, where the computational power of our microchips, and especially our graphical processing units, has really skyrocketed over the course of maybe the last decade and a half. And you can see as computational power increases, there's a lot of AI-related companies even in the medical domain, such as Overjet in the dental domain, really start to emerge, taking advantage of the big data that is available and also the big computational power that is then enabling our processing of this data. Now, there's a number of different ways how to think about different AI algorithms, and there's a number of different ways that you can split them up. Maybe talking about supervised versus unsupervised learning is something that you may have heard of. But I believe if we're medical professionals, if we're clinicians, one of the best ways to really think about this differentiation is from the clinician's perspective, which is sometimes two algorithms might be very similar or even the same from a machine learning standpoint, but if the way they're used in clinic is substantially different, then that is something we as clinicians need to take into account. So the classification of AI algorithms in clinical practice that we have proposed looks something like this. We have diagnostic modeling, prognostic modeling, and generative modeling based on what the output of the model is and when that is applied. So I think this is a very important slide, so I'm going to just take a minute to explain this in a little more detail. So if I use a diagnostic model, then that means the model's output can be checked against the ground truth, or let's say the real diagnosis at real time. If I, for example, take a radiograph, take a photograph, take something like a blood test and apply some sort of AI algorithm to diagnose something, the likelihood is very high that we have alternative diagnostic methods. And so I must trust my AI algorithm, but I also have a way to check it. Now, this is a substantial difference between diagnostic and prognostic modeling, because a prognostic model's output refers to the future. That is something where a prognostic model might identify a patient having a higher risk factor, being at a higher risk of developing a complication, developing a disease, an adverse event. And if that's in the future, there is no way of knowing in the present how accurate that model would be. So it is very, very important to trust that model. And the third is generative modeling. Now, generative modeling, there's no way to check the output in the present. There's also no way to check the output in the future because there is no output unless I use the model. So there's no diagnosis, there's no prognosis. The model generates new data. And of course, in medicine, for diagnostic purposes, for clinical care, that might not be as relevant as something like diagnostic modeling. But for example, medical education, dental education, creating patient cases for immersive teaching and learning, and examination situations, I think generative modeling really has a future there. And of course, thinking about dentistry, you can see that dentistry is a very data-rich specialty of medicine. We have imaging data, we have numerical data, we have textual data, structured and unstructured. There's really a lot that you can do with dental data in AI. So in the short time that we have today, I would just like to give you a very brief overview into the different modeling types and what you can do with each of them. So in prognostic modeling, right now, regression is really the basis of a lot of prognosis. If you think about identifying an association and extrapolating that into the future. The problem with that is regression modeling, if you estimate the parameters, beta, 0, 1, and however many parameters you have, those also, by definition, take into account the clinician's own opinion of feature selection, right? You can only ever put things into your regression model that you have thought of. And the things that you have thought of, they are in that model. So there's a human bias in here. And something that has really not been used in dentistry up until a couple of years ago is something that is really on the boundary between traditional statistics and machine learning called penalized regression, where you apply an advanced, almost learning or similar to learning phase in the modeling, where the model is able to learn from the mistakes it is doing and is able to penalize these parameters and even correct if a clinician thought of including something as a predictor that is in fact not predicting anything. So to give you a practical example, this is something that we have done for postoperative neuropathy after third molar removal in the mandible. So identifying factors such as distoangular impaction or disadvantageous curving, but also patient-related parameters such as prior psychiatric conditions with a fairly reasonable diagnostic accuracy, which we have published about 3 years ago. Now, taking it even more one step further, you can really apply advanced machine learning algorithms to the same problem. For example, here you can see a random forest algorithm that is creating multiple decision trees. So multiple trees, this is where the forest comes from. And it's a random forest because each of these decision trees is fitted to a random subsample of the patient population. And all of these decision trees together come together to help classify something or predict something. So in the case of these wisdom tooth neuropathy problems, this is something that we are working on currently. This is just a portion of what a real-life random forest would look like. This is something that is currently work in progress. But prognostic modeling, a big topic, because as we usher in the era of precision medicine, precision dentistry, it is very important to be able to tell patients their own individual risk, especially as it relates to disease development, risk stratification, adverse events, complications. It is really the future to be able to tell patients not just, well, this is a risk factor, but no, Mr. John Doe, I believe this is your exact risk of this exact adverse event. Of course, diagnostic modeling is one of the most important pieces of machine learning and AI in all of medicine, especially as it relates to feature learning in images, where these algorithms, computer vision algorithms, are able to learn from the images and classify the images according to diagnosis, or maybe find anatomical or pathological structures on these images. It all depends on what you do with the image, what you teach the model, or what you let the model learn. And this is something called labeling or annotation. You can, of course, start with just classifying an entire image, but you can also tell the model exactly where to look, and your model might be able to detect where a wisdom tooth is, as you can see in the middle. But you can also make the extra effort and label teeth very precisely with polygons or masks, and you can segment away individual anatomical structures. And of course, this works very well for highly precise automated diagnosis of pathologies, but also just even charting, dental charting finding teeth, numbering them, creating a dental radiology report automatically. Again, this is not a commercial lecture, but I just wanted to give you a couple of examples of what a software might look like. This is one of the companies that are doing this in America, Overjet. This is a second company doing this, as you can see, also in three-dimensional radiographs. So the slide I showed you earlier with the segmentation masks, you can see that that also works in 3 dimensions, and you're really able to just after the model, after allowing these models to learn from a big data set of anatomical imaging, now they can segment away a new patient's CT data set, allowing you to take a deep look into these anatomical structures. Also, you can actually act on this data, and this is clinical data from a good friend of mine, Sam, who works with me at Harvard. And this is merging data from an intraoral scan and a cone beam computed tomography, where of course you can take the crown from the scan and the root from the radiograph and simulate a tooth extraction and do precision guided implant surgery, simulate an immediate implant placement, even with the tooth still being in the jawbone, because the AI algorithm helped you simulate a tooth extraction. Now, some of the things that commercially available software is yet unable to do would be something like finding jaw cysts and tumors. So this is where we have done some prior research using the algorithms I've shown you before of object detection and object segmentation and the random forest classification of not just finding the cyst, but then also classifying it, whether it is odontogenic or it just happens to be in close proximity to the tooth, but is actually not odontogenic in nature. And of course, what good is an AI algorithm if you don't compare it to experts? So in this study that we have performed, we have also compared our AI algorithms to 10 clinicians from 7 countries based on 300 radiographs. And you could see our AI algorithms actually performed quite well, even against people who are experts in oral maxillofacial radiology. And this is a work that is really an international effort, also involving colleagues from the ITU WHO AI for Health Global Initiative. And this was published 2 years ago. It is open access. I really recommend this. It's such a good group effort. Really thankful for the team on this. And of course, with software such as Gemini and ChatGPT and DALL-E and Midjourney, all in the media, it is very important to talk about what generative modeling means for us clinicians in medicine, in dentistry. So if you have ever used Google, autocomplete works by predicting your next keystroke based on your previous keystrokes, right? So if I had typed in my, then of course the next keystroke is probably a blank space, right? But then afterwards, whatever key I strike, that influences the prediction of what probably the word is going to be, what I meant to type. So if I write an F, that might be family or friends. But if I type in a P, that might be phone or patient. Now, if I type in a T, that might mean I was going to type tooth. But the more information I provide the system, the better these predictions get. So if I don't just write my, but I also write my tooth, then of course the prediction gets a lot better, because my tooth, maybe it does hurt, maybe it is sensitive, maybe my tooth is broken off. So as you can see, the more I give the model, the better this prediction gets. So of course, what would happen if I took all of the publicly available textual data on the internet and provided that to a model to learn from and try to predict the next keystroke, the next word, the next sentence? And of course, this is exactly what a large language model does. So if I type into ChatGPT this exact question, what will happen is the model tries to predict if this was just one text box what would have been the text following my question. And of course, clinicians and patients alike are in love with generative AI and large language models. But even though these models are showing very high speed of development and they can actually answer some seriously impressive manner, especially if it's an easier question, I still urge us clinicians to be cautious, because it doesn't take a world-class expert to show that these models are in fact able to provide bad information convincingly, such as in this example where I have asked a large language model what kind of membrane I should use in a dental procedure called guided bone regeneration if I want to avoid a second surgery. So of course, avoiding a second surgery means the membrane should be resorbable. And of course, the model actually recommends 2 non-resorbable membranes out of the 4 that it gives me as an answer. So there's really room for improvement here, which will come. But in the meantime, there is definitely caution that we need to take as clinicians who are working with patients whose outcome depends on what we do. And finally, with this short overview on AI in dentistry, I would like to call your attention to the global initiative. Unfortunately, we still only have the old logo, which was from the time that we were called a focus group. After 5 years of successful work, this has been morphed into a United Nations global initiative between the ITU, the WHO, and the WIPO, the World International Property Organization, where we're working not just on developing AI and doing research with AI, but also benchmarking, standardization, and helping facilitate the implementation of AI, especially in lower resource countries. So you can find us online. It's the Global Initiative on AI for Health. And of course, if you want to reach out, if you want to contribute, we are always welcoming new participants. But with that, I would like to thank you so much for the attention. Thank you so much for the invitation. I hope that even in this short time frame, I was able to at least wake your interest in relation to artificial intelligence and what it can do in dental medicine to improve patient outcomes and contribute to the global mission of better healthcare for all of us. Thank you.
Thank you, Dr. Feher. This was a very interesting presentation, especially in the recent boost of artificial intelligence. So I'm sure that our viewers appreciate your information that you've collected in this presentation. And I'm very, again, thankful for your contribution to this International Medical Erasmus Conference, because this was my first time organizing it. So I am very happy that we managed to gather such a great group. A Harvard fellow, this is a very great contribution. So I thank you again for sharing this knowledge with us and for contributing your time, which is so valuable.
Happy to contribute. And thank you again for the invitation, and congratulations on a great event.
Thank you. I hope that we will be able to invite you to some future events as well. Okay, and so as we approach the end of the conference, I would like to extend our gratefulness to all the speakers and participants who made this event a success. So thank you for joining us, and we look forward to seeing you at our next conference, which might be next year. I would also like to extend our heartfelt gratitude to our patrons, Minister of Health, Izabela Leszczyna, Śląska Izba Lekarska, IFMSA-Poland, Director of the Medical University of Silesia, Professor Tomasz Szczepański, the Student Scientific Association of the Medical University of Silesia, and the Student Government Association of the Medical University of Silesia. I would also like to thank the sponsors of the quiz prizes, Compendium Medicine, Corpus Mind, Eldan, Medantlers, Medycyna Praktyczna, PZWL, and Więcej niż Lek. Your support has been invaluable in making this event more interesting. Thank you everyone for joining us today, and thank you viewers if you are looking at the transmission after our event has already finished. Have a great day and hope to see you during one of the student exchanges.
Na myśl o studiowaniu medycyny lub wykonywaniu zawodu lekarza często rodzą się w nas wątpliwości. Z czego i jak się uczyć? Jak zdobyć praktyczną wiedzę? Gdzie szukać wsparcia innych? Wyobraź sobie miejsce, które dostosuje się do Twoich aktualnych potrzeb edukacyjnych. Miejsce, w którym możesz zadać każde pytanie i uzyskać odpowiedź. Miejsce pełne atrakcyjnych i praktycznych materiałów edukacyjnych, które same się aktualizują. Tym miejscem jest portal Więcej niż lek. Znajdziesz na nim kursy e-learningowe, stworzone tak, aby umożliwić Ci efektywną naukę w atmosferze wzajemnego wsparcia, rozwoju, zadawania pytań i uzyskiwania odpowiedzi. Koniec z wertowaniem podręczników przepełnionych litym tekstem czy korzystaniem z nieaktualnych materiałów. Już dziś dołącz do wirtualnych pokojów nauki, dzięki którym wspólnie z innymi będziesz efektywnie uczyć się z materiałów edukacyjnych dostosowanych do Twojego etapu rozwoju zawodowego, podczas studiów, przygotowania do egzaminów końcowych czy w pracy lekarza. Więcej niż lek to medyczny portal edukacyjny, wspierający efektywną naukę medyków oraz pomagający im w świadomym budowaniu zawodowych kompetencji. Dołącz do nas. Ucz się i lecz świadomie.